Morning. It is June 26, 2025 at 9:04 a.m. The board meeting of the Oregon State Board of Nursing is now called to order. A notice of this board meeting was published by Rachel Prusak, Executive Director, in accordance with the open meeting law. If necessary, the board may also meet in executive session as authorized by ORS 192.6601, ORS 192.6602F and L, ORS 678.126, ORS 676.165, and ORS 676.1751. Board members and staff stating if they are present are attesting to understanding the confidentiality of executive session and have taken steps to ensure that the session proceedings are not observed and not authorized by public meeting law, ORS 192.660. Is there a roll call by our president-elect?
Yes. Marcus Cooksey.
Present.
Margaret Hill, present. Claire McKinley Yoder. Excused. Joni Callis. Here. Linda Stanich. Present. Olaniki Toabola. Present. Rachel Dennis.
Here.
Nesta. Here. Rachel Mitzel. Here. There being a quorum present, I declare this board eligible to conduct its business.
Would the executive director like to do a staff roll call?
Yeah, good morning, everyone. It's great to see you in Southern Oregon. I am going to start with our virtual, we are sending virtually. Maybe having some trouble with her mute. Fox.
Sorry, this is Sarah, policy analyst for APRN's board staff.
Great.
And this is Philip Fox, licensing manager.
Great, thank you. Selena Redbird.
Hi, this is Selena Redbird, board staff and policy analyst assistant.
Great, thank you. And I'm going to head over here to our policy analysts just to announce themselves, starting with Baru.
Barbara Jew, policy analyst for nursing assistant education, board staff.
Laura Blackhurst, policy analyst for nursing education and board staff. Gretchen Cook, policy analyst for RN, LPN practice and board staff.
Great, thank you. And Philip Young.
Board IT staff.
Brandy Ritter.
Executive assistant.
Lauren Rauch, board counsel.
Kimberly Goddard, chief of staff.
Great, and Rachel Prusak, executive director. And before we jump into the board, I just want the few public members that have already arrived to be able to announce themselves. And again, just had someone share with me that they've been waiting decades to come to a meeting, but can't drive to the Portland metro area. So again, we're very, the community is very excited to be here. And I know that many will be joining throughout the day.
I'm Joanne.
All right, and I think, I have one more staff. I have their name up there now. So John Etherington.
John Etherington, board staff.
Great, and I think that is all. The rest of our staff is watching via our live stream.
Are there, so we have the agenda in front that was announced ahead of time. Are there any modifications or changes we want to do?
No, Mr.
Okay. So then that moves us to the approval of the consent agenda. So on were there any, as you all pull it up, were there any modifications or questions? No, sounds like not. Then we want to make a motion to approve the consent agenda.
Sure. All righty, Mr. President, members of the board, I make a motion that the consent agenda items be approved as presented.
So move.
Seconded.
Roll call. Cooksey,
Aye.
Hill, aye. Callis,
Aye.
Stanich,
Aye.
Towabola,
Aye.
Dennis,
Aye.
Nesta,
Aye.
Mitchell.
Aye.
The consent agenda has been approved.
Great. Then the next item is on page 20, the meeting minutes from our April in-person meeting. Were there any modifications or anything, any corrections? Okay. We're ready for the motion then.
Righty, Mr. President, members of the board, I make a motion to approve the meeting minutes from April 16th, 2025.
So move. Second.
Roll call. Cooksey,
Aye.
Hill, aye. Callis,
Aye.
Stanich,
Aye.
Towabola,
Aye.
Dennis,
Aye.
Nesta,
Aye.
Mitchell,
Aye.
Ms. Pass.
We can now turn to Policy Analyst Blackhurst to present on Division 21. And
Good morning again, Mr. President and members of the board. So again, I'm Laura Blackhurst, your policy analyst for nursing education. My item is on page 36 of the packet regarding proposed revisions to divisions 21 and 51. Following the presentation of draft rules to you in April, we did hold a public rule hearing on May 20th. We received one public comment expressing positive feedback for some of the changes. I'm bringing this back to you today for final approval, but before I ask to bring a motion, I have one additional edit to some of the wording. That change would be on page 44 of your packet. And as you flip, I'll give you the line. So on page 44, we're looking at Rule 0045 on nursing faculty, and the line is 1A. So at the April meeting, a board member, McKinley Yoder, raised a discussion around adding the word nurse into that line, which you see here. However, after the board meeting, we realized that inserting the word nurse actually can add an additional barrier because nursing programs can have non-nurse faculty. So like a pharmacist teaching a pharmacology course is a really good example. The intent in our discussion was just to make sure that a nurse is really evaluating those final clinical outcomes. And so the proposed edit I would like to make is in that line 1A, we actually delete the words classroom or, and so the intent remains the same, that the final evaluation of student learning in clinical must be done by a nurse faculty member. So I'm happy to answer any questions you have about that edit or the impact. And if not, I have several motions for this one. All right, then my first motion is that the board approve the permanent adoption of the amendments to OAR 851-021, 0000, 0010, 0015, 0025, 0035, 0040, 0045, 0050, 0055, 0065, 0070, and 0090 as modified effective July 1st, 2025.
So move. Second. Roll call. Cooksey,
aye.
Hill, aye. Callis,
Aye.
Stanich,
Aye.
Towabola,
Aye.
Dennis,
Aye.
Nesta,
Aye.
Mitchell,
Aye.
Motion carries.
All right, then my second motion is that the board approve the permanent adoption of OAR 851-021, 0012, and 0051 as presented effective July 1st, 2025.
So move. Second. Roll call, Cooksey.
Aye.
Hill, aye. Callis. Aye. Stanich.
Aye.
Kawabola.
Aye.
Dennis.
Aye.
Nesta. Aye. Mitchell.
Aye.
Motion carries.
My third motion is that the board approves the permanent repeal of OAR 851-021, 0018, 0020, 0030, 0060, and 0080 as presented effective July 1st, 2025.
So move. Second. Roll call, Cooksey.
Aye.
Hill, aye. Callis. Aye. Stanich. Aye. Kawabola.
Aye.
Dennis.
Aye.
Nesta. Aye. Mitchell. Motion
Aye.
carries.
All right, my final motion is that the board approves the permanent repeal of OAR 851-051, 0020, 0030, 0040, and 0050 as presented effective July 1st, 2025.
So move. Second. Roll call, Cooksey.
Aye.
Hill, aye. Callis. Aye. Stanich. Aye. Kawabola.
Aye.
Dennis.
Aye.
Nesta. Aye. Mitchell.
Aye.
Motion carries.
Thank you very much.
Before we move on to the next item, I just want to publicly thank policy analyst Laura Blackhurst for the amount of work that has been done over the last year plus with our collaborative partners across the state in academia and clinical and anybody involved in education. It has been huge and amazing. And thank you to the board for giving guidance and along the way. It's pretty big work to remove barriers and support our academic institutions.
Mm-hmm. Thank you. Thank you. All right, the next item on our agenda is from Policy Analyst Cope.
Good morning, Mr. Board President, board members. I respectfully request the board considers the permanent adoption of proposed amendments to Oregon Administrative Rule, Chapter 851, Division 6 of the Nurse Practice Act, which contains definitions for terms used throughout the other divisions. These proposed amendments are in support of the amendments just passed by for Blackhurst for consistency with the Chapter 21 standards for approval of nursing education programs, preparing candidates for licensures as RNs and LPNs. The board approved these proposed amendments to move to administrative rule hearing during the April board meeting. Administrative rule hearing was held virtually on May 20th with no oral or written testimony given in favor of or in opposition to the proposed amendments. So respectfully, I present the following motion. That the board approve permanent adoption of amendments to OAR 8.
I think we have, hang on one second, we have some clarifications.
Okay, thank you.
Sorry.
And we'll come back to you for that.
Page 105. So 851-006-01905. I'm on page 105. It is the clean version copy. And we didn't catch this before. The second line, documentation 5 of the need, if we can just, and that's apparently that's been there for a little while. So we need to remove the numeral 5, please. Now.
And I have one question here, point of discussion here. Page 97, the definition for alternative to discipline. Number 8.
Almost there, hold on.
So yeah, page 97, number 8, alternative to discipline. So that reads that the alternative to discipline program for registered nurses and licensed practical nurses with diagnosed substance use disorder. There is a potential that CNAs and certificate holders could be a part of the alternative to discipline program. I wonder if we could change the language to program for licensees or certificate holders, or what would be kind of what would be language that might leave it a little more open?
Yeah, that one is in the hopper. My RN policy analyst, which is going to come after this, I presented draft rules of Division 6 that tackles the definitions. So that is one that we will be amending to make consistency with the current bill passage and everything else going forward related to the alternative discipline program.
Thank you for that. Okay.
Yeah, Division 6 with definitions is definitely always ongoing, but it's always a good idea to elevate to make sure that we're catching all the things that could be potential changes. And I do have one thing that needs clarification though for the previous Scribner error for the documentation 5 of. Is this also written this way in Division 21 that we just adopted? I think that we have to clarify.
Policy Analyst Cook, I'm wondering if that definition was a definition that was proposed to be changed, or if that would be a change to a definition that wasn't part of the original rulemaking, that would be something we'd want to add to the future changes.
For the definition of statewide need, is that what we're saying?
Yeah, is that the definition that Board Member Hill had the correction to?
I'm going to jump to the track changes.
Before going back to what President Cooksey just said, there is a period missing
It's
in that number 8.
Yeah, they're still looking through the.
Right.
this one you brought up.
I apologize. I wasn't tracking.
Yeah.
I was checking in the track changes version of the state needs. So I'm assuming that's artifact error on Secretary of State's website when it was entered. Because we did not make modifications to that definition.
Yeah, I don't know. That's why I said I think
okay.
it's been in existence for quite a while.
Okay, thank you.
So I just want to make clear that since it wasn't a definition that was being proposed to be changed, I think that's something we would want to look out for a future change. And it sounds like there are already some changes in the works. So maybe Policy Analyst Cook, you could add that
Yes.
to the list of ongoing work, just to make sure that you're staying within the scope of your original proposed rulemaking.
Going back to number 8, the alternative to discipline, there's a period missing. Known as the Health Professional Services Program, period. Successful completion.
Okay, noted. Thank you.
Okay. Thank you.
Oh, you're right.
Any further discussion or clarification or house cleaning?
I think we're ready for the motion. Thank you.
Okay, thank you. So the proposed motion is that the board approve permanent adoption of the amendments to OAR 851-006, rule number 0010, 0030, 0060, 0130, 0140, and 0190 as modified, effective July 1, 2025.
Can we clarify, were there modifications to these particular definitions, or were the modifications only for future rulemaking?
Oh.
No, is this the
Well,
period?
The period,
I think was the only.
Was that in a definition that was part of what was being proposed to be changed, or is that?
because it was the
definition-
HPS piece, or
Oh, that's correct. So they went to be, so it would be as presented.
Yeah.
So would you like me to repeat the motion?
that is
please?
what is as
Thank you.
presented.
So it is proposed that the board approve permanent adoption of amendments to Oregon Administrative Rule 851-006, rule number 0010, 0030, 0060, 0130, 0140, and 0190 as presented, effective July 1, 2025.
So move. Seconded.
Roll call. Cooksey,
Aye.
Hill, aye. Callis,
Aye.
Stanich,
Aye.
Towabola,
Aye.
Dennis,
Aye.
Nesta,
Aye.
Mitzel.
Aye.
Motion carries.
Thank you, Policy Analyst Cook. So we are moving on a good schedule here to Executive Director Prusak.
Thank
A number of
you.
items for us.
Yeah, our goal today is to keep us on schedule and make sure that you all, hopefully we leave at 2 since we all have a very long drive home. I look forward to the Scribner errors coming up on all my many presentations, but here goes. So I'd request that you all turn to page 120 of your board packet and request that the board initiate a motion for proposed rulemaking concerning Oregon Administrative Rules, Chapter 851, Division 70 of the Nurse Practice Act. This division outlines the standards related to the Health Professional Service Program. In September of 2022, the board voted to withdraw from the Health Professional Support Program. And to suspend both self-referrals and board-ordered placements into the program, with the cessation taking effect in October 2022. Over the past year, I have presented current evidence-based insights on alternative to discipline programs to our staff and the board. As a result, the board has voted to re-engage in HPSP, and today I request the proposed rulemaking changes to Division 70. I'm going to go down the list, okay? To repeal 851-070-0010, to adopt 851-070-0011 to include purpose, intent, and scope of HPSP. Repeal 851-070-0025. Adopt 851-070-0026 to include participation in HPSP. Adopt 851-070-0027 to include eligibility for HPSP. Adopt 851-070-0035 to include procedure for board referrals to HPSP. Adopt 851-070-0041 to include procedure for self-referral to HPSP. Amend 851-070-0051, revision of disqualification criteria for clarity. Amend 851-070-0060, revision of approval of independent third-party evaluators for clarity. Amend 851-070-0070, revision of approval of treatment providers for clarity. Amend 851-070-0075, revision of approval of worksite monitors for clarity. Amend 851-070-0080, revision of licensee responsibilities for clarity. Amend 851-070-0090, revision of completion requirements for clarity. And amend 851-070-0100. And just for some background, what all of this really means is, for clarity, where I added that, as I was updating and adding back in for us to re-engage, I wanted to make sure that our rules were more clear, as well as including CNAs. The thing that the board has been talking about for a long time. One of the reasons that the board voted to leave in 2022 was feeling as though it was inequitable, that CNAs couldn't join. We do know there'll still be some barriers for cost to them, but it is a huge undertaking and support of equity that the board is moving towards this. And with the work to increase fees, we're able to budget for this. And I'm really proud of that work. But now I am here to take any questions or comments on Scribner errors.
Okay.
This was a lot of work, so I am
Yeah.
sure there's some of them.
So Director Pruzak.
Yeah.
Page 123. Now I did this in the red line, so
We should do
so the 0700026, the second line, and may refer eligible certificate holders or licensees.
Mm-hmm.
Then in the next section, 0020, this 0027.
Mm-hmm.
It looks like there might be a return missing between section 5 and section 6.
Oh, yeah. And also maybe, oh no, because here I say the certificate holder. So it doesn't need to be at.
No, it's referred,
But-
self-referred certificate holder.
Mhm.
Yeah, some of these I got holders. Yeah, so that again is the possessive S. Does that need to be in that last one or not? Under 0035, so this may be sort of a blanket question.
Yeah.
Because it's that same thing on the certificate holders or licensees professional practice. It's missing the apostrophe,
Which line?
the very last line.
Okay. Okay. And what are you suggesting on that one?
Well, I'm just on the certificate holders.
Okay.
So the
Okay.
apostrophe licensees has it. Then on 0041, and this again, this is a question. We've got a self-referral, and then other times we actually list out a self-referral certificate holder or licensee.
Mm-hmm.
And so that's my question on that is for, do we want to set a standard and use that throughout, or does it not matter?
Can you give an example? So
Okay,
fully.
so the very first one, a self-referral must, and then under section 2, we say a self-referred certificate holder or licensee must.
Yeah, I see what you're saying. And I think when I mentioned for clarity, I was trying to make things more clear. And I wonder if when I did that, by having the heading up above and everything to be included in it, that some things were missed. I bet you that's what happened.
So that's my question on that. Thank you all for letting me.
No, I welcome them.
And then again, that's
I want it to
that's
be
in a few
perfect.
different places.
Right.
So
let me propose that, because as you know, there's the intent is here and there's nothing that we want to do to hold this up any longer.
right.
Given, the motions that I'm about to make and how we're doing this is that we will host a rule hearing in July and come back to you for that very brief virtual meeting to finalize it so that in September we're in it. So I'm thinking I can propose that I go through for the intent of, what would I describe that as? I don't want to say like grammar. Yeah.
Yes.
So when I present the motion, would I say as modified or would I say as presented with some keeping the intent, but some of the possessive grammar errors?
Yeah, because that's what it is.
Yeah, I think an option would be for the board to, for the motion to be as presented with direction from the board to look at further grammatical revisions.
Okay,
love
During I'd consider those as part of the final.
great.
rule.
Great. And I had a feeling that there'd be a few here because at first
Yeah.
I felt, oh, we're just going to re-engage. I'm just going to put back in the old things. But of course, I didn't make it that simple. I made it the work that needed to be done.
Yeah, and there's just, I have like 2 more of the possessives.
I'm sure I'll find them when I do the
Right.
grammar check, but if you want to shout them out, I'll take them down.
Okay, 0070
Mm-hmm.
B, certificate holders or licensees. So again, that apostrophe S.
Okay.
And then 0075 2, certificate holders.
Yep. Yeah, this is definitely from sentences that had the certificate holder versus certificate holders.
Yes.
So I'll catch all those, and I think maybe you can write that down for me. Oh, good. Write down my motion, not what I'm keeping track of everything, but
Motion's going to be the same.
but with the direction for grammar. Yeah. Anyone else have any questions or comments?
I have one on page 122 where we talk about the scope and intent. We
I'm
use,
sorry, I can't hear you.
sorry.
Yeah.
A little closer, better.
Yes, thank you.
Page 122 where we talk about the scope and intent,
Mhm.
we use the word disease. And when there's a definition, in the very last item in our packet, we did use the word disease. So I don't know if we want to be just a little more consistent with how we
Mhm.
describe this so that we're really clear in our communication.
Mm-hmm.
That'd be my only comment.
Yeah, so what is the other, I looked at, again, for this clarity, I looked at how the other boards that are engaged in it were describing it, and I bet you that's where I grabbed that from. But I think we should be consistent. So what is the other piece that you mentioned for me to compare it to?
The very last item in our packet, there's a policy towards.
Oh,
this.
yes, yes,
So I thought we should be the same.
yeah. And you're talking about how we describe it as disorder, substance use disorder?
Yes.
So let's think about that. So substance use disorder is a chronic disease. So that's where that is, because the diseases is description of mental health diagnosis and substance use disorder. So it's an umbrella of it. So it actually does make sense here if I explained it properly anyhow.
Editorial on that, because so I think this is the language here of calling it out as a chronic disease is part of the substance use communities and medical communities' desire to elevate this as a diagnosis, right? As you well know, and because a lot of the traditional belief system or sort of common belief system to this day is still, oh, it's a personality flaw, or it's those people over there. Versus when we recognize disease, all of us can get diabetes, all of us can get high blood pressure, all of us could get substance use disorder, right? So I think that's why that is added there.
Yeah, I don't have an issue with it. I just.
No, thanks for the question. It helps.
Consistent.
Yep.
Mhm.
And so it ultimately is by, thank you for bringing up that I brought the internal policy back to you all for an update. But yeah, it makes sense in this space of describing both in this way for the scope. But I appreciate it. And I appreciate it.
Well, this is really exciting. It's regrettable that we've had 2 years now that Oregon nurses have not had access to an alternative to discipline program. And so I really commend staff and executive director for really taking this on. And sometimes maybe renewal is the best way to make it better, despite it being regrettable we had those 2 years. One question, one thing I'd like to talk a little bit more about, because as you mentioned, the inclusion of CNAs as well as cost as a barrier. Now we know that the alternative to discipline programs have been very effective at enabling nurses in their recovery, as well as continuing to be able to work and monitor a safe practice. So we know that they're effective, that they're cost effective. However, the cost for licensees and potentially certificate holders could be a huge barrier. And I have a lot of worries about how effective the model we have in HPSP will be for CNAs related to cost. When the typical cost per licensee is around $3,000 per year for them to pay for principally for the testing fees, as well as evaluation fees. So I read this over time. There are some ideas, but I wonder where executive director, where we're at with exploring how to enable CNAs to participate and be able to make it affordable, given that their earnings are so much lower. $3,000 a year would be a huge chunk of their earnings.
Mr. President, members of the board, I'm thankful this discussion we're having. I'm thankful we're at a place we're getting back in. And I really do look forward to figuring out what is that next step that can be taken to support that once we're back in. I'm not sure it will be, from fiscal responsibility of the board, or maybe it is future work in the legislature where they allow expenditures for that. Maybe it is partnering with the hospital systems that are going to maintain their workforce for someone that's in it with their in-house labs. Maybe it's partnering with payers throughout the state. These are the conversations I really am looking forward to. I just needed to get here. And now once we're here, it's a real conversation to be able to have. And just like, some board members and some staff have come with me, we have formed relationships, collaborative partnerships. I actually just got appointed to be the secretary on the board for National Organization of Alternative Programs. So really digging into what is happening across the nation, because some are very successful with supporting CNAs. Some have separate programs. So here we have this first step, and I very much look forward to, locking arms with the board and all of our partners across the state to figure out what does that look like.
Thank you. Yeah, thank you for, those are some good ideas, and it's some future work we have. I think, yeah, you highlighted a few of the areas that we've seen success in other states, 43 or so, 44 other jurisdictions that provide alternative to discipline. I think a great step would be if we can find partnership with the hospital groups to kind of at least waive their fee. The other thought, one of the other ideas out there was creating like some sort of support fund that could be donated or that could come out of fees. And then another one that we've seen that in the Florida Alternative to Discipline is that they handle different levels of licensee. The monitoring that they do is slightly different. So they'll do, for example, like for their treatment evaluation, they'll have a more affordable treatment thing, or they'll decrease the amount of testing that they do in order to engage more CNAs. And so that's something else I think we should explore.
Absolutely.
As you brought up, the other states, we're not inventing the wheel here.
Absolutely.
Other states.
Yeah.
Question.
I think you and I have talked about this at a different time, but is there any state that actually does allow for, if we're saying it's a chronic disease, health insurance? And so it may be when I'm long gone off the board, where is this down the future that we push for that? Because again, health insurance, but is there any state is my question at this point?
So, board member Sanich and members of the board, I think that I can't say 100% there is. Whatever space that I'm in, I elevate that as part of the discussion. I think it's real opportunities, and I bet you there is a model. I bet you it is happening in some spaces. And I think that it's definitely something to talk about. I think I need to just figure out, right? Like as the director of the board, I bring collaborative partners together to discuss it, of where others feel responsibility to support their workforce. And that is where that conversation will be. Because it's not like I can or we can regulate that in any way, but I can definitely form those partnerships like I always do and have and will to have those conversations. And I do think that needs to happen. And it probably is. I just don't know 100% yet. You will be the second to know when I know. Okay.
As a point for education, like the cost of fees, about 30 to 40% is the collection fee. And that's the thing that I think is the lower hanging fruit, where we could have
It is?
hospital groups able to
Yep.
waive that. I think that's one that's easy. I think my understanding is traditionally medical insurance has viewed these as like ordered or forensic testing that is not medical. And so, but maybe there's some opening for, if it was ordered by the medical provider, it could be the same test. And then maybe that would be different. So I look forward to.
Yeah, and the only downside I hear about using the hospital system lab, not only does it help with having to take time off to go drive sometimes an hour to get to a lab, it's just about that confidentiality of making sure it's the worksite monitor plus the manager plus now maybe the lab. But again, as we continue to remove stigma and as we continue to focus on maintaining workforce and how is it affordable, I'm hopeful those kind of things change too.
Yeah, I want to highlight one change I like that was in a couple of different places, was changing the language to testing rather than saying urine testing, because there are there's even virtual testing where they can do it on video and they can do mouth swabs or finger sticks or hair, and get that same level of quality where they're doing the monitoring piece. So there's a lot of new opportunities for testing that may be more convenient for licensees than the usual pee in a cup thing.
Yeah, 100%. And, now that we're back in a program, we have a third-party vendor as well as our compliance specialist. We're having these conversations, listening to the updated language, and slowly but surely, that is what we will see, especially as I get to come forward to you all once we get through the legislative session, that legislature 100% passes the bill, we come back. So this will continue to evolve, but we'll be back in it, hopefully, after my motions.
Any other observations or questions? Great, I think we're ready for the motions.
Okay, and then I will probably need a little bit of help with as directed by the board.
I think that has to
Ah,
be part of your motion.
Oh,
Yeah, so my understanding is the board gave direction to look at those grammar revisions as part of the process, but I don't think it needs to be part of your vote.
perfect. Okay, perfect. All right. Board President Cooksey and members of the board, I make a motion that you approve initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed amendments to OAR 851-070-0051, 0060, 0070, 0075, 0080, 0090, and 0100 as presented.
So move.
Second. Roll call. Cooksey.
Aye.
Hill, aye. Callis.
Aye.
Stanich.
Aye.
Towabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitchell.
Aye.
Motion carries.
Mr. President, members of the board, I make a motion that the board approves initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed adoption of OAR 851-070-0011, 0026, 0027, 0035, and 0041 as presented.
So move.
Seconded.
Roll call. Cooksey.
Aye.
Hill. Aye. Callis.
Aye.
Stanich.
Aye.
Towabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitchell.
Aye.
Motion carries.
Great. And the last one, I make a motion that the board approve initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed repeal of OAR 851-070-0010 and 0025 as presented.
So move.
Second. Roll call. Cooksey.
Aye.
Hill, aye. Callis.
Aye.
Stanich.
Aye.
Towabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitchell.
Aye.
Motion carries.
Thank you, everyone. All right. If I may move us forward and keep going, I am going to direct you to page 138. So members of the board, this is coming to you because of policy law that was passed in the legislature last year. So I respectfully request the board initiate rulemaking in Division 1 to implement SB 1552 from 2024, which is now found in ORS 670.2804. This ORS allows individuals to petition a licensing board prior to beginning an educational program for a determination as to whether a criminal conviction would prevent the individual from receiving a professional license or certificate. This criminal conviction predetermination process is new, so OSBN does not have an existing process for these types of petitions. As background, these determinations are limited to whether a particular conviction prevents the person from receiving the loan certificate, are not final orders and do not generate contested case rights, are not considered investigations and are therefore generally public, should be made in the same way the board decides on an application where the applicant has a criminal conviction. I'll continue reading if you'd like of what this does, but the new statutory language sets some perimeters, including when a determination that a conviction will not prevent licensure or certification may be rescinded, and when a determination that a conviction will prevent licensure or certification must be reconsidered. Some parts of the process, like what needs to be included in a petition for it to be complete, that the statute does not expressly address. However, the statute allows licensing boards and agencies to adopt rules to implement the new statutory language. Accordingly, the draft rule language included in the packet aligns with the statutory language and provides more detail on the petition process. Because this is a new process, board staff worked to be deliberate in our approach to implementation, which resulted in fully developed process, which is now before you. And just for reference, it's all of our licensing boards have been directed to adopt this. But temporary rules are necessary because the statute has a July 1st, 2025 operative date, and there's a need to avoid any undue delay to prospective students wishing to use this process. I'm the board to consider issuing both a notice of proposed rulemaking to initiate the permanent rulemaking process and adopting temporary rules to have a process in place more immediately. A set of proposed rule language is included in the packet for your consent, and I'm requesting that the same language be considered for the temporary rule.
So Director Prusak, I
Yes.
have one question.
Yep.
And that is on page 142. 0009 subsection 3. It says a civil penalty of a minimum $500. That seems like a lot.
Yeah, go ahead.
Is this already exist? Is this, so we don't have any say over that?
Yep. This is law. And go ahead.
This is law.
Yeah, Board Member Hill, the rule language that you're talking about isn't part of the proposed amendments right now.
Okay.
So it's if that's something you want the board or board staff to take a closer look at in the future, that's one thing, but
Okay.
this isn't actually sort of what Director Prusak is proposing as the amendments for implementing this particular statute.
Okay. Thank you.
Yeah, this comes from years of a senator working to ensure that those that pay for their education and receive their diplomas then are not subjected to not getting their certificate or license. And this is licensing boards, not just the Board of Nursing, every licensing board across the state. Yeah.
I have a question. Does this look at is there a differentiation between crimes committed as children versus crimes committed as adults?
So
The line about expungement and juvenile. At least I remember that line, but
yeah, so the way I understand it is that we're basically running the criminal background check the way that we do them for their license. So that is exactly following our current statutes. So there are some, pieces in there. For example, to speak to exactly what you're talking about was the theft greater than 5 years, right? And then that doesn't preclude you. So I think that's what you're getting at. And I think one of the intents was to kind of make sure that we are not preventing our workforce and just, but you know what, I think I'm not going to speak to it a lot because I don't fully have all of the answers for this. This is very new for all the licensing boards across the state. But I think there's a lot of discussion that needs to continue now that this piece happened, including how our academic institutions are doing theirs. And does it align? Don't know.
Yeah, those are good questions. And not just that piece, but my mind was more going towards like MIP piece or minor in possession, or because the kids that graduate from nursing school probably are 22. So how far is that look back? Are we looking far back, or is this something that's going to be now part of our process coming to the board to make a determination on when kids start their college career programs, whether or not we are predetermining whether or not they can be licensed?
Yeah, so to speak to it more directly versus what I did answer is in section 7, under no circumstance shall an applicant be denied under these rules because of a juvenile record that has been expunged or set aside pursuant to ORS 419A. 0.260 to 419A.262. So that's exactly what President Cooksey was speaking to, and hopefully removes your concern.
Yes, thank you.
Not that we could change it because it's a law that we have to implement because it was passed, but it's a great question. Yeah. But, and also that was I know the intent of the senator who's worked on it for a long time.
Great. Well, July 1st is very soon.
Yes. Yes. All the
I think we're ready.
are making this happen.
I think we're ready for the motions.
Great.
A lot going on July 1st for DNAs. Okay.
I'm checking with my expert rulemaker / Secretary of State. Master. Yeah.
Just to provide a little bit of context for sort of what's happening right now. Thank you. So it sounds like the board staff in working with Secretary of State on rule filing procedures has learned that the rule number 010 we're proposing actually can't be used. Number needs to be changed 011. That change was identified after the draft rule language was prepared. So we're going to be asking that that number be changed to 111, and so the vote would reflect a modification specifically to address the rule number issue to avoid any kind of procedural issues in the rule filing process.
So can I just ask a quick question before I make these motions? Do I say 1 and say modified? Okay. Okay, Board President, members of the board, I make a motion that the board approve adoption of OAR 851-001-0111 as modified as a temporary rule effective July 1st, 2025.
So move.
Second. Roll call, Cooksey.
Aye.
Hill, aye. Kellis.
Aye.
Stanich.
Aye.
Koabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitzel.
Aye.
Motion carries.
Okay, members of the board, I make a motion that the board approves amendment of OAR 851-002-0055 as presented as temporary rule effective July 1st, 2025.
So move.
Second. Roll call, Cooksey.
Aye.
Hill, aye. Kellis.
Aye.
Stanich.
Aye.
Koabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitzel.
Aye.
Motion carries.
Okay, I make a motion that the board approves initiating the rulemaking process by providing notice and opportunity for public comment on the proposed adoption of OAR 851-001-0111 as modified.
So move.
Second. Roll call, Cooksey.
Aye.
Hill, aye. Kellis.
Aye.
Stanich.
Aye.
Koabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitzel.
Aye.
Motion carries.
Great, and our last one, I make a motion that the board approve initiating the rulemaking process by providing notice and opportunity for the public comment on the proposed amendment of OAR 851-002-0055 as presented.
Roll call, Cooksey.
Aye.
Hill, aye. Kellis.
Aye.
Stanich.
Aye.
Kowabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitzel. Motion carries.
Okay, Mr. President, we had originally put that I would be going from 9:30 to 10. It is 10, and I still have 2 more motions for rulemaking. I should have known we would have talked about Division 70 a little bit more when I timed it. How are you all feeling? Does anybody need a break, or can I keep going?
I think you can keep going, and Manager Fox is okay to come back, I guess, later. We'll delay his time a little bit,
Oh, yeah.
I guess.
Yeah. Unless we want to let him go and then I come back.
Let's give you a break.
Let's give me a break.
Let's give
Okay.
you a break and
Yeah.
let
Yeah.
Manager Fox.
He's ready.
Licensing Manager Fox, are you prepared?
Yes. Can you see me okay?
Yes.
Yes. Okay, great. Board President, members of the board, I have our first licensing exception request from our new rule 851-031-0052. Applicant Julius Mugo Mwangi graduated from Concord Career College in Portland, Oregon on November 23rd, 2022. Mr. Mwangi has attempted the NCLEX LPN on 3 occasions, March 17, 2023, July 11th, 2023, and July 25th, 2024. On November 23rd, 2024, Mr. Mwangi's application for LPN by exam expired with the Oregon State Board of Nursing, and Mr. Mwangi is requesting a licensing exception in accordance with OAR 851-031-0052. Mr. Mwangi is requesting an exception to OAR 851-031-00153A, which states applicants for initial licensure by examination, not previously licensed in another state or country, will be permitted to test no more than 2 years following the program graduation. Mr. Mwangi cites Rule 851-031-00155D and states 851-031-00155D, re-examination following 1 or more failures up to the 4 attempts allowed. An exception to this rule would allow me to test for the exam 1 more time. If granted, Mr. Mwangi would submit a new application for LPN by exam and would be permitted to. Are there any questions?
Thank you. I have a question. Does the gentleman have a plan in place? Because, he's not necessarily more likely to pass the more you take it.
I don't know if he has a specific plan, but we do allow for 4 attempts for people within 2 years. So this would just be giving him the same number of attempts as most people that are attempting the NCLEX in the first 2 years.
Thank you for bringing this forward. I had a question about the time. If the board were to approve an additional attempt, is there a time limit on that extra?
There would not be if we get granted an exception to this rule.
And we're not able to circumscribe a time?
So when this was brought forward to you all, it was brought forward because of the conversations that we're having, around Operation Nightingale, and that the recommendations were to do attempts versus years. And currently, remind me, Licensing Manager Fox, about, is it 28 days? Every 28 days they can test?
45
when it was
days.
2 years? Thank you. I knew I was wrong. So every 45 days they can retest. So they can potentially, when we had it 2 years, take the test a lot. So this allows 4 attempts with no time frame. And that is the more common way that it's being done across the country. So that is, I'm sure just based on graduation, people aren't going to wait forever because of, and that was the thing. We were getting exceptions because someone would be 2 years in a week. because of something that happened after graduation. So this kind of allows for that without the time frame. So I hope that helped.
I have a nit. I'm sorry. We're using his first name in the motion instead of his last name. Is that typical?
You know, that might just be my error, not continuing to use his last name.
Okay. I maybe modify the motion to say Mwangi instead of his first name.
Absolutely. Any other questions before I make the motion as modified?
And does it really need to be modified? I mean, if the motion's not.
Because it's in writing.
So I think you can read the motion to reflect the person's name. The modification is you're just updating the motion language. So this would be, I think the motion could just read to grant the exception to the rule with the person's name. And you don't even need the as presented.
Thank you.
It's modified.
I'm sorry, Ella, I'm not sure if I fully caught everything you just said. I'm having a hard time hearing.
Yeah, so I think Licensing Manager Fox, the motion language could read, based on the information presented, the board grants Julius Mugo Mwangi an exception to OAR 851-031-0015 sub 3 sub 8 or A. And just that would be the motion.
Okay. Well, I would like to make a motion that based on the information presented, the board grant Julius Mugo Mwangi an exception to OAR 851-031-00153A.
So move.
Second.
Roll call. Cooksey.
Aye.
Hill, aye. Callis.
Aye.
Stanich.
Aye.
Kawabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitzel.
Aye.
Motion carries.
Thank you.
All right, members of the board, thank you for that little break, and thanks to Licensing Manager Fox for bringing that first exception. I'm gonna request that you guide you to page 182 of your board packet. I respectfully request that the board initiate a motion for proposed rulemaking concerning Oregon Administrative Rules, Chapter 851, Division 002 of the Nurse Practice Act. This division outlines agency fees. In September and November 2024, the board discussed and voted to approve a modification to OAR 851-002 licensing fees to increase all LPN fees by $35 and RN fees by $100. During the 2025 legislative session, OSBN presented our budget to the Ways and Means Committee and received approval. The next step is for the board to support proposed rulemaking. So today I request the proposed rulemaking changes to Division 02, amend 851-002-0010 to adjust fees, amend 851-002-0020 to adjust fees, amend 851-002-0030 to adjust fees, and lastly, amend 851-002-0035 to adjust fees. I'm open to hear any comments or questions.
For my own edification, where do certified nurse midwives land in the breakdown? Because I see there's clinical nurse specialist, and then there's nurse practitioner.
Nurse
It's all
practitioner.
under nurse practitioner.
Mhm.
Okay, thank you for that. All right, sounds like we're ready for the motion.
Great. So I make a motion that the board approves amending OAR 851-002, 010, 020, 0030, and 0035 as presented as a temporary rule of July 1st, 2025.
So move.
Second.
Cooksey.
Aye.
Hill, aye. Callis.
Aye.
Stanich.
Aye.
Kawabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitzel.
Aye.
Motion carries.
Great, and one more. I make a motion that the board approves initiating the rulemaking process by providing notice and opportunity for public comment on the proposed amendments to OAR 851-002, 0010, 0020, 0030, and 0035 as presented.
So move.
Second.
Roll call, Cooksey.
Aye.
Hill, aye. Kellis.
Aye.
Stanich.
Aye.
Kawabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitzel.
Aye.
Motion carries.
Great, I'm gonna move on to my last division work and guide you to page 197 to discuss per diem reimbursement days. And I respectfully request that the board initiate a motion for proposed rulemaking concerning OAR Chapter 851, Division 10 of the Nurse Practice Act. This division outlines the standards related to board member compensation, OAR 851-010-0024. So as you know, effective October 1st, 2024, the daily per diem rate was set at 178, applicable for each day or any portion of a day in which a member performs official duties for the board. And as we transition away from virtual meetings, the materials for the upcoming 2-day board meetings will be more extensive, making it necessary for additional preparation for board members. So currently board members are reimbursed for 4 preparation days when attending a 2-day meeting. However, during the last meeting, board members requested that I draft a proposal to increase this to 5-day preparation days for 2-day meetings. And this adjustment, I share what the per diem rate is, changing this adjustment, as well as I spelled out for you all what the days were and what they will become. Open to any discussion on that, but hopefully I kind of heard the discussion correctly and came with a fair proposal.
I think we discussed this well in the last session, so thank you.
You're welcome.
Ready for a
I'm
motion?
always paying attention and hoping I hear it correctly and able to bring it back. So members of the board, I make a motion that based on the information provided, the board approves the proposed board reimbursement dates as presented.
So move.
Second.
Roll call, Cooksey.
Aye.
Hill, aye. Kellis.
Aye.
Stanich. Kawabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitzel.
Aye.
Motion carries.
Great. And my second motion is I request that the board approve initiating the rulemaking process by providing notice and opportunity for public comment and holding an administrative rule hearing on the proposed amendments to OAR 851-010-0024 as presented.
So move.
Second.
Roll call, Cooksey.
Aye.
Hill, aye. Kellis.
Aye.
Stanich.
Aye.
Kawabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitzel.
Aye.
Motion carries.
Great. So all of my request for rulemaking is complete. And I will turn it back over to you and wouldn't mind a small break if you were willing to call for one.
Yeah, now could be a good time. Take a 15-minute break and come back at 10:30. Analyst Koch.
Thank you.
Cook.
So my practice and evaluation agenda item today is for information, and that is that work continues on the Division 6 definitions. It's an ongoing definition, vision that's always open, working on that for clarity, if terms are still needed, for grammar, for random artifact. So work's going to continue on that throughout the summer. I anticipate bringing it back to the board in September for additional feedback, and then you can provide direction at that time.
And that. Great, and I think that's it.
And that concludes my section unless there's other questions or discussion concerning the division.
Thank you. Policy Analyst 2.
Mr. President, and members of the board, if I may direct your attention to page 226, my memo on CNA consolidation effective July 1, 2025. This is informational only. I believe all of you joined the board after the CNA consolidation work was already underway. So I wanted to share briefly some of the background information. Thank you. Can you hear me okay? Okay. After receiving feedback in June 2022 from CNAs and legislators that there were too many years becoming a CNA in Oregon, board began a lengthy public process. After almost 3 years of public process work of listening sessions and rule advisory committee meetings to determine the best way to move forward, based on information received during this sessions process, the board determined that maintaining 2 levels of CNA no longer made sense in the current healthcare landscape and did not significantly impact patient safety. So in June 2024, the board voted to combine the 2 CNA levels with an implementation date of July 1, 2025, to give ample time for employers and education programs and CNAs to prepare for the consolidation. So next week, Tuesday, after almost 3 years of this process, the CNA1 and CNA2 designations will be retired, and there will be 1 level of CNA in Oregon. So as of July 1, nursing assistants who currently have the additional CNA2 designation will appear on the OSBN license verification portal as a CNA. Any questions or?
Thank you for all your hard work and all the other staff's work and getting ready. July 1st is very soon. And I know it's been months or years of work now.
Thank you.
Great. So we have 12 minutes for either our panel to start. If we could, I don't know if we have something we want to move or if all of our panelists
That's
like
actually
to start early, which would be the better?
great idea. If I could do the agenda item that's at the very end and move it now, and then we'll stay on time for our panel
we get
presentation.
Minutes for that. And
Yeah. Oh, I love this.
Okay.
And thanks again for moving the break up. We did a lot of work in a row. So then, if everybody is okay with that, where do we go?
So it's
We go to page 301.
301.
Give me 1 minute to get there.
We might need 3.
All righty, board members. At the April board meeting, the board decided to transition away from virtual meetings and introduce an additional 2-day board meeting in 2026. Please see the attached schedule of proposed board meeting dates for 2026 for review, discussion, and approval. And those board meeting dates are on page 303. And as you can see, we the main adjustment is moving September to October and adding December in person. And the other something up for discussion if you want to have strategic planning in April or in October. So that's something for you all to discuss.
Board Member Hill, did you?
That had been my question had been about the board retreat. And I can see if we have it in April, then we're addressing things as we have new board members join us. They're getting there could be opportunities for additional training maybe. But then the benefit of having it later in the year is that all of the board members have been participating for a number of months and may have firmer opinions and more awareness of.
Well, the interesting thing about that is, one, board members are kind of always rolling on.
Yes.
We did have a time where it was a large amount at once, times two, there was 5 and there was 3. That's not typical. So the one piece that I could add to this conversation, I think that is interesting is we owe the governor's office and the state our kind of strategic planning in June. And so when I came to you last time, the leadership team had worked on it, and then I had to submit something, and then I asked you all, where do we go from here? What are you thinking? And I look forward in September to sharing with you what we discussed again for our updated strategic plan, again, for your input. But what I could see as an April advantage point is you contributing to it before I submit it originally versus me amending it afterwards. But again, that is the only thing I see, but I make it work either way.
I think it's a great idea for the second meeting of the year to have that board retreat. Because when I was remember last year, I could have used that more, as you know, as everyone here knows from me talking and asking a lot of questions. I could have used education to kind of like balance having some experience, having gone through one full session, I think would generate enough questions and thoughts. And then, it's a 3-year term. So the full year you have another one where you continue to grow and evolve. So if we were to just have one, I think it's better to have it in that second session of the year.
In April.
Yeah.
I like April. It's getting warmer. October it's starting to get cold, and I don't want to be shivering in the room.
We could have some of our education outside.
Sounds good to me. So April sounds great.
Rachel?
Mhm.
Maybe it's just a question, thinking it's been a lovely travel trip to Ashland, Oregon. I guess my question would be where they would like us next or visiting in this year of the 2026. Do you have any ideas?
Thank you for bringing that up for here. Yeah, so as we know, we'll be on the coast in September. So the goal is to get to Eastern Oregon when it is weather appropriate for us to go. So you all could decide that we do that April or June. I don't know if our Eastern Oregon board member has a thought on when it is best time to be Eastern Oregon, but I do think we'll do one travel, and that will be it as Eastern Oregon. So is it in April when we have a 3rd day, so you're not driving really far overnight and you can stay 2 nights? I think that could be an opportunity too.
The weather in Eastern Oregon usually is always nice.
Good answer.
I would be concerned that April there could be snow. That would be my concern with April.
June there won't be.
June there wouldn't be. I don't know if it gets too hot in June.
No, the best thing about Eastern Oregon is that it might be hot during the day, but it usually cools off at night. So,
And if you all,
I was going to say there are a lot of great places to go, and I can give the board some suggestions if you don't have any ideas.
I look forward to it. So I also could say, no reason we didn't make June an opportunity for a third day, because we could also adjust that. No, it still wouldn't. Yeah, and that would change though, right? I submit everything on June 1st to the state. So if we really do want to have those discussions before, April would be the best to have the 3-day. Again, I've made it work, but if we want to do Eastern Oregon in June and maintain the board retreat in April, we can still do it off site somewhere, but.
We have two questions. One is whether to have two board retreats. Oh, yes. No.
No, I was proposing one board retreat,
Okay,
asking you guys to
see.
pick, yeah, that would be a
Okay.
plan too.
Then, thank you.
Sorry that I was
I was
confusing
looking
you.
at it, I was like proposed, doubly proposed. Okay, so it sounds like April is a good time to do the retreat, not in October. So October would be 14th, 15th. And then the other question is when to do which session in Eastern Oregon.
Mhm.
I'm hearing a preference for June, a few. Same as this time of the year. Great.
Mhm.
Hopefully before fire season.
I know, here too.
But would the June still be 2 days,
Yeah.
correct?
Yeah.
Yeah, I was in Eastern Oregon last year in June for the listening tour when I did this whole, and there was fires, but, yeah, but it's a sad state that we're planning around that, but it's just the truth. I could make a suggestion that we plan for April, but if weather permitting, we move it to June, but then we'd have to vote again, wouldn't we? Everything we do is public, so we make our decisions in public, so we would have to, even the dates we meet.
I think April in Eastern Oregon is great.
Let's do April.
Most likely we would be on 84, which is currently held open, so.
When we say.
So there's, yeah,
what
we
does that
haven't
mean?
identified that yet, but I was in LeGrand and we were able to connect with the academic institutions there as well as the hospitals. Of course, there's further Eastern Oregon we could go, but if we wanted to kind of allow for, some to drive in and us to drive out, open to suggestions. You have suggestions?
No, I was going to suggest LeGrand or Central Oregon.
Mhm.
Both of them have nursing programs.
Mhm.
Could be good to kind of show presence
Mhm.
that it had a hospital system and educational program.
I think LeGrand's a good area because it captures Ontario,
Mhm.
Pendleton, the farther east.
So if I'm tracking correctly, we're going to keep April the 3 days with the board retreat, and it's also when we will do our travel in LeGrand to Eastern Oregon to continue to get out of the Portland metro area like we're doing today.
Yes.
All the other dates seem okay? All right, then I am going to make a motion that the board, based on the information provided, approves the proposed board board meeting dates. I'm going to start from the top.
Do it.
Thank you. I make a motion that based on the information provided, the board approves the proposed board meeting dates for 2026 as modified, with April being the date we chose to include our board retreat, as well as the time that we travel to Eastern Oregon.
So move.
Second.
Roll call. Cooksey,
Aye.
Hill, aye. Callis,
Aye.
Stanich,
Aye.
Kobola,
Aye.
Dennis,
Aye.
Nesta,
Aye.
Mitzel,
Aye.
motion carries.
And so that we don't keep our guests waiting, I will save the other last agenda item for when it fits into the time-wise. the timeline. And just for, and we have lots of invited guests for panel discussion, and the way the room is set up, we will do it in 2 sections. And it looks like we have everybody from Klamath Falls here. Okay, I will let you take it from here, President Cooksey.
So we're moving on to page 220 packet, and we're inviting our guests here from various institutions, school and health institutions, from what I understand, here in Southern Oregon. When I say you speak into the mic and you first please yourself, when it's green, like you see here, it's hot, and you can just leave it on the whole time if you'd like, or just when you speak, but please, we have an order here. So the folks from Warner Pacific University. No, sorry. Oh, wow. I'm totally reading the Sky Lakes. There we go. We have folks from Sky Lakes. So go ahead and please introduce yourself.
Good morning. Thank you for having us. My name is Christy Wiles from Sky Lakes Medical Center, and I am the Senior Director of Hospital Nursing.
Hey, good morning. Thank you for coming to Southern Oregon. I appreciate you being here and taking this time. My name is Ron Woyd. I'm the Chief Nursing Officer and Chief Operating Officer for Sky Lakes Medical Center.
Hi, and I'm Cindy Neubauer. I'm the Director of Training and Development at Sky Lakes Medical Center. Thank you.
Hey, I'm Dr. Dorothy Neufeld. I am the Director of Medical Planning College in Klamath Falls.
Great, kick us off.
Okay. We started kind of having some thoughts around what this would look like here today, really looking at different ways to address nursing wellness. The Oregon Center for Nursing actually a couple years ago kicked off a nursing well-being grant process that started us off kind of thinking about how could nurses improve the well-being of our team members. And so, Christy, could you talk about the relaxation stations?
Yes, I'd be happy to. Yeah, that's been a highlight for us and for our teams. But it was really an inspiration that was brought forward by one of our nursing managers, our critical care manager, Jennifer Jacobs. She had been to NTI, the National Institute for Critical Care, and she had seen this concept of a lavender room. Lavender is soothing. It's typically isn't that, things kind of. So she brought the concept back, and we put our own Sky Lake spin on it. And she wrote up a proposal to create relaxation stations, is kind of the term that we called. And we were fortunate to be able to carve out a space of them, one on our med-surg floor and one on our critical care floor. And they are spaces that are really, it's a really relaxing space. So we focused on colors. So we opted not to go with the purples, and we put our own spin on it, but we kind of have these really relaxing blue tones. We have bean bags. We have zero gravity chairs. We have soft lighting. We have soft, drapery on the windows. And it is really a space that is just truly designed for clinical staff. And it spreads beyond nursing and CNAs, but in a place to go to really get away. There's no food allowed in the space. You can have a drink, but no food. And no, if you want to use your phone, that's fine, but you have to do it on silent or have your earbuds in so that people can really have a place to get away and relax. And it has been a tremendous success.
So one of the things is, and you'll hear this through of trying new ways to do things to support nursing. COVID was hard on nursing, and not even outside of the metro areas, the rural areas were really hit hard. And more importantly, it is harder to recruit to those rural areas. You know, we've talked about in the past where there's a maldistribution of nursing in the state of Oregon and some of those pieces. And so we were really trying to figure out, how do we retain our nurses and our team members? Because it's not just about nurses, it's nurse practitioners, it's physicians, it's CNAs, it is phlebotomists. And so, you know, there was a program, I have to give credit to Stacey Holmes, our trauma program manager at Sky Lakes Medical Center, because when I came to Sky Lakes back in 2011, one of the things she introduced me to was critical incident stress debriefing. And really, this was centered around the emergency department. So when we ran into challenges where we had a pediatric death, we had a big trauma, multi-person fatalities on the highways, that we had a way to help keep our team members healthy and keep them healthy, but also being able to care for patients going forward. And what we found out over a number of years was that while we saw critical incidents as things like gunshot wounds and children who die and these big gory things, what we didn't realize was if there are people working in primary care physician office and they have one of their long-term patients die in front of them, that is traumatic for them. And so we had to look at a way, how do we expand this to really meet the criteria of what a critical incident debriefing look like? And it really is a situation where you are faced with something that is very traumatic and it is a surprise to you. So like if an ambulance call goes out and they say you're going out on a 99-year-old male and you end up and it's a 9-year-old male, that is a surprise. And so that increases that risk for trauma. So how do we continue to take care of our team members through these traumatic situations? Well, what we found out was that as we started having conversations, that it was more than just the patient care that was impacting our team members. And so we expanded that not only across the organization, but moved into a place called peer support. And really the idea behind peer support is so that you have a unit, you have an individual on your unit who is specially trained just to kind of debrief with. Healthcare is hard. We see some bad things. We see some bad situations, and you can't go home and talk to it with your family. And so we tried to figure out what is a way that we could build a system that would allow us to care for our team members. And so what we've done is we designed the system called peer support. We actually have 58 of our team members who are trained, especially in peer support of team members. 38 of our departments have a peer support person in them. And this really gives us that opportunity for people to have those moments to kind of just debrief about what's going on. And what we're finding out, it's not, while the work we do is hard, life is hard. And so the impacts, the social impacts of what's going on around us while we're trying to be caregivers, not only at work, but at home, does drain on our care, our ability to care. And so this peer support team really is available. Actually, we have a 24-hour. If we need to bring in a team, we can bring in a team. But generally, we have a peer support member on site 365 days a year, 24 hours a day, so that there is always somebody available. And they have a pin to wear so that you know that you're talking to somebody who is trained, and it allows you to get that off your chest so that you can go on being the mom, being the dad, being the nurse, being the doctor. So this group is not just of nursing. We have a surgeon. We actually have a couple surgeons. We have ED docs. We have respiratory therapists, EVS. All areas of the organization are covered by peer support.
Yeah, and if I could just add a couple of comments, is that, I think we tend to say, don't bring your personal life to work with you, but the reality is we do, but we also take our work home with us, right? It weighs heavy on us at times. And so it's not just about those traumatic events. It's about the incremental insults, that you experience. And you never know when it's going to be that moment when it's going to be too much. And oftentimes what we find with our team members is it's a little thing that pushes them over the edge, right? It's that compounding trauma over time. And that's on top of whatever trauma you bring with you from life.
from your life experiences. And so that's something that I think that this system addresses in a way. Like critical incident debriefing has its place, but this is what gets at that, just that everyday life. So.
Okay. So another opportunity that we utilize, and thank you for approving the licensure for the nurse interns. And so Cindy Neubauer has headed up our nurse intern group, and where you may, I don't know if you've looked, but about 90% of all nurse interns in the state of Oregon have been at Sky Lakes. It is a program we've embraced and tried to maximize it, as well as that opportunity to better understand how a student learns through that process.
The nurse intern program has been really amazingly helpful for staffing. Is that one of the things with all the staffing laws and as far as doing things go, is that these nurse interns from the hospital's perspective gives us a little bit of an extra cushion. It gives us an opportunity to ensure that all of our patients really get the very best care that they can, because you have like that extra person there. I'm going to speak now from the student perspective, is that we have now, I believe 9 have finished their year as seniors and gone on, and some of them will be joining our nurse residency program. From their perspective, I'm waiting to see as far as their NCLEX pass rates go, but their confidence level as they have been nurse interns for this period of time, their confidence has grown exponentially. And then we'll start measuring that as they get into the new grad program. But they have had the opportunity to do what I call think like a nurse. Because in school, we're really focusing on the academia. We're really focusing on giving in this tremendous body of knowledge about nursing. And it's compared to when I graduated, it's just grown exponentially. And so they're busy memorizing all of these things. And it seems like there's been less time for them to really practice and to really operationalize that knowledge into the everyday life of a nurse. And so I believe that these nurse interns, from their perspective, are going to be light years ahead of their teammates who haven't had that experience. We've always seen that nursing students that had background in EMT, background as a CNA, actually they put things together quickly because they've had that lived experience. And so it's fairly new, but from both the perspective of the hospital, of staffing, and from these new grads' perspective, this has been revolutionary to our ability to really provide both the hospital with extra staff and these students with an amazing experience of the lived life of a nurse. So.
And we see that on a regular basis, just talking with the interns in the hallways, and they're so excited because they got to see ICU, they got to be in the ED, they got to be in all the different areas. So they really kind of have a good idea of where they want to be, versus like when I come out of nursing school and it's like, okay, I'm gonna go in this area. I hope I like it. They've had all those experiences. But that really kind of tails into our partnership and our relationship in rural health with our partners in academia. Mammoth Community College, OHSU, the School of Nursing are very important to what we do. And what I like is, especially I'm a ADN nurse at my core, and that's where I started at. And so I truly appreciate KCC and really looking at some new ways of how do we recruit, how do we educate, and how do we onboard some of our future nurses.
Okay. Well, before I start speaking, I'd like to give you a couple of statistics just so you can put this in perspective. I wish I had more specific to the counties that we have, but this is for a 5-county area. It's Deschutes, Jackson, Josephine, Klamath, and Lake. Klamath Community College obviously is located in Klamath Falls, but we also provide education to nursing students in Lakeview. They are employed by Lake District Hospital, which is a critical needs hospital. So we are looking at 2 hospitals that my program serves, both of whom need nurses and have more vacancies than they need people. I also have a nursing home in my area that is not at full capacity right now. Why? Because they don't have enough nurses. So as an educator, how do you get people into the profession and manage the space that you have in a smaller rural community? Give you a couple more statistics as to why this is a really big problem. As far as nurses greater than 65 years of age, that's about 6.3% of the workforce. So any of those people could retire at any moment and we would have more of a deficit. The 55 to 64 demographic in these counties is also 18.5. So if you add the 2 of them together, you're looking at about 25% of the workforce is over the age of 55. So we have a problem now. We're going to have a bigger problem in the future as people opt to retire. One other stat before I continue on is males in these 5 county areas in nursing is 12.3% and a female is 87.3%. Okay. Also, we also have 19 to 24-year-olds. We only have 3.5% of the group in the workforce in healthcare, and that's as LPNs, RNs, and NPs. Okay. Again, I wish I had more breakdown for you, but that's kind of the stats that I've got from Lightcast data. So what we're looking at is I came here from Florida and I was in the Tampa Bay area at State College of Florida, which is in Sarasota, Manatee counties. It's a much larger school than KCC. But what we were looking at was we had to compete with University of South Florida, Galen, couple of other nursing schools, Kaiser, all the EMT programs, all the other medical programs, and you've only got so much hospital real estate for students to come in on, right? And I was at a hospital, my primary hospital was about the same size as Sky Lakes is. So it was kind of interesting that I was going from where I predominantly was to another section. But what we found was there were so many students there that eventually we ended up asking, could we do an evening clinical? Evening clinical there ended up being usually from 6 at night till 2 in the morning. We also instituted a Saturday clinical at Sarasota Memorial Hospital. Sarasota Memorial is a clinical site. So we were able to convince some of our day students to consider going on Saturday to promote what they saw as the most prestigious and also kind of got their foot in the door to Sarasota. And for those that were in my group, I was the evening girl at Lakewood Ranch Medical Center. And when I went around the room and asked everybody, I was kind of surprised. Most of them, the reason for doing it was quite simply, they were not morning people. They were happier then. I am a 20-year night shift girl, and I know stuff happens at night at the hospital. And unfortunately, sometimes people that are traditionally day shift workers, they think all people do at night is sleep. And I can tell you, no, they don't. They really don't. And if anything, you have, I think, better opportunities for students because the room is quieter, the lights are dimmer. If you have a student with issues with perhaps a diagnosis of ADHD or that, it's just a calmer environment to try to learn in. There's more access to sit at the desk. There's more access to get a computer. There's just a lot of pluses to being there in the off hours. The minuses are that sometimes you miss the opportunity to maybe go to cath lab or maybe go to the OR, but sometimes those opportunities can still be yours. So what we found eventually was we ended up, instead of just offering those 2 as clinical placements, my school opted to start an evening weekend program. So classes were given in the evening and they did Saturday or evening clinicals. What turned out was we found this is just anecdotal, I can't really give you stats on it, but it was a totally different demographic than who I saw in the daytime. It was moms that were staying at home with tiny little kids. It was somebody who worked in heating and air conditioning that literally worked outside Monday to Friday, 8 to 5, and then came to class. That's how he got through nursing school. So when we look at things like the stats I gave you on males, maybe if we offer a different alternative, maybe we're going to get different people coming into the program who really want to be nurses but can't do that Monday to Friday days situation. So this last application process, I ended up listening to the interviews for everybody, found we had some really qualified applicants. And I'm the kind of person that I hate saying no to people. I really do, especially if you seem good. Like, why should I say no to you? So I reached out to Cindy and to Ron and said, look, I've got some good ones here. Can you maybe help me with a Saturday clinical so I can take some more in? And I'm happy to tell you that the answer was yes. And we are going to be able to take in 2 extra LPN transition students and somewhere between 3 to 4 LPN students. So it's a little step, and we're still looking down the road to expanding that, but we're making our first steps towards making this a reality. We're also reaching out to high school students through the early credits that they can take in high school to try to up that young demographics where they could get into nursing right away. And the other thing we're doing is one of my coworkers is a lovely gentleman, and we have now made him our poster child for males in nursing, and literally made him the poster child. We have a big poster of him now. And it's got him doing, like, you know, kind of the game, you know, the sports look to it, but it is going to be promoted to younger guys because, again, why are we missing them in our demographic? And they often come into nursing as second career. So why aren't we getting them when they're 18? It's a question, right? So together we're trying to make it better because we all live in this community. We all have health needs, and we need to train a base of people so that they're there for ourselves, our families, and for everybody in Klamath and in Lake County as well.
Thank you. So members of the board, I wanted you to, and there'll be another panel, have an opportunity to meet those that I met on the listening tour and share kind of like a real life of what the things that we're talking about, what we're voting on, what we're thinking about. So whether it's that wellness piece or the nurse intern piece or the clinical practice partnerships. And I knew in Southern Oregon, there was some really innovation and creative things happening. So for the record, I did also include OHSU as they are part of partnerships in the nurse intern, but a great person who works in academia gets to take a break. And so while they were a part of the listening to talk about nurse intern and present some of the challenges, despite the challenges though, they set it up. And you know, we as a board had removed those challenges and barriers. And so thank you for presenting and then here for supporting a discussion.
I'm definitely passionate about both these subjects. And so I work all around the state, and I've kind of asked different people, especially when they let me know that they're a clinical instructor, what they would think about doing clinicals on nights and on weekends. And has that been a challenge for you to find clinical instructors that are willing to work these off shifts?
Yes and no. One of my coworkers, he is the one I was talking about. He's okay evenings. For the partnership we're looking for the fall, Sky Lakes is going to try to find a day 12-hour shift for Saturday. It can be a problem, but at the same time, there are people like me that if you gave me the choice of being at the hospital at 5:45 in the morning or in the afternoon, I'm taking the afternoon, you know. And for students too, honestly, I always call it the Goldilocks med pass, but when you do your evening med pass, it's usually not this massive list of 20 pills that make most student nurses cringe. It's a manageable small list. There's usually a few oral meds, there's usually sliding scale insulin, there's usually an antibiotic or an IV push. So you get enough of them having something without feeling totally overwhelmed. And then you can pick up other opportunities as they come along in that setting. So I've found it's been okay. It's just finding those right people. And also, I have in the past had day shift people want to be clinical adjuncts when I was in Florida. And literally for the 2 of them in particular that I'm thinking of, they would do clinical adjunct for 12 hours on Thursday. So that meant they could not work Wednesday night and they could not work Thursday night. So if you have people who currently night shift that are interested in becoming clinical adjuncts, it's been much better with their normal schedule and doesn't take them off schedule by this opportunity for students.
Yeah, and I will add, Laura Blackhurst and I meet with deans and directors across the state quarterly, and we hear that it is a challenge. So what you're hearing is, but I think what we're hoping for is more conversations around it. But so here's an example of sharing that, but yeah, a lot of spaces, they're sharing that it's a challenge.
Okay. And then the other question I had, I think that the idea of having some peer support specialists is a really great idea. I'm questioning, is it just talking, or are they trained to kind of help people develop skills to cope with stress, such as like cognitive reframing, or do they have any power to say like this person really needs an extended break? They've had a traumatic experience. They need to step away from clinical duties right now. Or is it just kind of like on your own time, or how is that? And I think that having somebody to talk to is always great, but one of the problems I feel in hospital settings is that you're faced with this kind of dichotomy. You are the empathetic caregiver, but you're also a person doing a job. And so the job duties sometimes kind of overtake the personal feelings, or you have to kind of shove them down or put them. Are your peer support people trained to say, hey, this person really is struggling, they need a break from clinical duty right now, go to the relaxation room for 2 hours and we'll figure it out for you? I mean, what kind of, I heard was that they're there to have conversations, which I think is amazing, but what other kind of things can they offer?
Yeah, so they do, because, once you step into this realm, there is a risk that you are going to run into the individual who is suicidal or even homicidal, right? I mean, that puts you, it's just a whole nother level, but it exists there. And that's what we found, is it does exist. And it exists amongst our staff members, which is crazy to me. But it's there because we're all humans, right? I mean, we're just humans. And so what we typically do is there is an escalation process, but because there is a level of anonymity to it, you kind of have to ask. I mean, if it's suicidal, homicidal, that's one thing. But if you are, you need some time away and it's recommended that maybe you just need to go home today and maybe stay home tomorrow, then you have to get that permission to have that conversation with the manager, right?
Okay, I just didn't, I mean, I wasn't saying necessarily up to the point of suicidal or homicidal, just from acute, like having an acute stress reaction to a situation that was, like you gave the example of a pediatric death. That can be very stressful, especially if you're working in a small community and you know the family, or and you're dealing with a lot of the psychosocial things. If you have you have your debriefing and you have somebody that's just struggling, maybe they have a lot of things going on at home too. Are your peer support specialists trained to recognize like, hey, you're at a maximum, take a break?
Yes, they do. They are, and that is why we weigh. There's such a heavy weight placed on these roles, because they do have that, and we use that recommendation. Because if you have a pediatric death and you are tearful and you're too busy in your mind thinking about, did I do all the things right? Did I, all of the things? There's a chance that I'm putting another patient safety at risk. And so we have to react to that. Why I talk about the permission is because a lot of times we would never want to step across that trust. And even the numbers that are reported out of interactions never have a name with them. We do make sure, though, that if somebody is struggling, that we may follow up with them the next day or two, or even refer them to the EAP or to counseling. So it is more than that, and we do have the power to say, yeah, they probably shouldn't be here. They need to have time away, those types of things.
And I know that that's very difficult to deal with when a lot of times actions in nursing, especially with things like lateral violence, can seem very punitive. And your anonymous reporting isn't always anonymous, because when you work in small communities and small hospitals, all those incidents are pretty much known. I was just wondering, what your process was, or how you best support your caregivers. Because we had an interesting education before that said that that the number of nurses in our state was not decreasing, that just people were leaving nursing, but not actual leaving nursing, but leaving the bedside, basically. So I'm glad to hear that you're coming up with innovative ways to support people, but they have to, I think a lot of times we have really great ideas, but we need to think of them circumferentially. Like we need to.
Board Member Mitchell, thank you. Thank you. I think this is a great discussion. I just want to be mindful of time, and some of the other board members I can see wanted to get in this. It's a great program that I think that they have, and maybe we can have time afterwards to check in.
Can I just make one point?
Certainly, please.
I think this goes back to also to the education piece. What peer support does, it gives people the opportunity to grow, to learn and grow. One of the challenges with nursing right now is that, you know, when I come out of nursing and I'm on an ortho unit, I have 6 patients in front of me. 2 of them are getting ready to go home because they're like day 3. 2 of them are day 2 or day 3 maybe. And then we have 2 fresh post-ops. We don't have that anymore. Part of the challenge with nursing today, and I think some of our challenge as an industry and as a profession, is the fact that we have no variability in what we do. What I like about peer support and being a team member there, but also giving the opportunity to be an educator part-time, I think it's an opportunity for growth and create variability. Yeah. One of the areas we're moving into is mobile health because we have this vast area to the east of us. But that is another opportunity at variability and really driving that passion for nursing and the care of our communities. And so I just see this as one of those options because of the stresses of every day. And if med surg is not your specialty, you're just done there. Let's find someplace else. Let's help you grow so that you are still using those amazing nursing skills that you have and serving our communities.
Thank you for that.
Mine are quick questions. One, I appreciate coming down here to Ashland. It's been beautiful. Some of your ideas, I want to applaud you, can be duplicated in obviously the healthcare system, even where we come from. My questions are quick. In the room, is it a time allowed? I'm just curious, like, can they be on shift and how long is that time allowed when they can go there?
Yeah, it's obviously open to everyone on their, breaks and lunches, but I think there are those times where if there is something has occurred, or someone is just like needs a timeout, right? That space is there for that too. I think it's just there really are very few rules on how the space can be used, except don't stink it up with your food lunch, and be respectful of other people that want to use the space. And those are really the rules. And so we find that people are pretty respectful of that because they want the space to remain nice when they want to use it. So
thank you. One more question. The nurse intern, how many in the year have you actually had that joined and then you retained?
Like during the last. Thanks. During the last school year, we had 9 nurse interns and 8 of them are going to be in our new grad program. And so we did very well. A lot of the KCC graduates are now joining us in the nurse intern program. And so we've done phenomenal things because we know that school is very important. And so we're very flexible with when they're in school as far as making sure that school is first and that we don't interrupt that. So it's been wonderful. And so we will have more data this time next year about those 8 interns that spent a year or 2 with us and what that really looks like. So we're excited.
I'll just mention that the staff now on the units actually fight over the nurse interns. But it starts out like, I don't really understand this and what am I supposed to do with these people? And now it's like, oh, can we have them? We want them, right? So yeah.
And nurses are actually kind of fighting over who gets the nurse intern is going to be with them today. And so the nursing staff in the beginning was very, very hesitant as to what are we doing here? But now it is, everybody's excited to see the nurse intern be on their unit for the day. Yeah. We have 14 now that are going to be coming, but the ones that dropped off. And so it's always an ever-changing number, and we hire at different times. And so we did hire a bunch before school ended in the spring, and then we'll go through the summer, and then there are some people that may join us later in the summer or in the fall before school starts. So, but it's a fabulous way to integrate these new students into our world.
We've had a couple from our college. Typically it was a OHSU that they had, but there's a couple this time around from ours. Cindy came to speak with them and they decided to do that. But our students also have the option. So we're an LPN and RN program. So we do have the option of taking the boards in between. So some are choosing that path, some are choosing the nurse intern path. It's, you know, either way is going to provide them with great experience. But
Can I jump in real quick?
The time
So-
check.
Yeah.
And right, do we have we have
Yeah,
a panel here, right?
Yeah, we have another panel to present solutions from and clinical partnerships. So we should switch over unless there's any last burning questions. But I just want to say thank you for being brave to lead on the nurse intern before others, and I know now others will follow. Thank you for being brave and continuing to advocate for creativity, for clinical placements, and for sharing your wellness plans. It was great to see. And just for reference, Ron are you still on the OCN board? Yeah, is on the OCN board. So the information you were sharing, he's very much attached to OCN board. And they applied for a grant through the wellness grants that OCN gave out. They didn't get it, but they still lifted up what they applied for with that room. So, but thank you for allowing us to come to your community and for sharing with the board. And then if there's a burning question, go.
Board member Nesta get.
Yeah.
I worked in critical care for 17 years in the unit. I was the unit specialist before I became an LPN. And I will say that my manager was a big part in why we survived COVID. And he did try some of these where we had like little fan things, you know, like medication time, other things, but he was a critical care nurse before he was our manager, which I think is important because you understand the position. But with that said, at Kaiser, they did a program, speaking to your part, where they had trained a certain amount of people, right? You had to apply to get it. They paid for the schooling during the time, but they also let you do clinical there within Kaiser. And I would say we retained probably 90% of those people. There was no like you had to stay for a year or 2 years. You just got to be there. And most people stayed because why would we leave? That is so helpful. And I actually spoke to the director of critical care about redoing that, but it's so hard, obviously, to jump through certain things to get to that. But it was really important that they provided that. And I can see that that would be so beneficial. And I love that you guys changed your having weekends and nights, because I actually had to change my hours in order to go to school. And I was one of those 18 hours a day for a year and a half to get it done. Yes. And so for me, I was like, oh my gosh, this is great. And I love that you guys are doing this. And I love that you guys are realizing that we are just human and we all get stressed out as well. And it's very, very helpful. And I actually watched a traveler nurse come to our unit, and there was a shooting in the garage, and she came in and was like, I'm totally fine. I'll go to work. And we were just like, what? Absolutely not. We like made her take some time before but it's just her thinking was like, I got to take care of these patients. So I just
All that going in nurse mode.
Yep.
Yeah,
Survive.
I just thank you guys. And I was so glad to hear the whole panel. So thank you.
Thank you.
Yeah, thank you for having us. Yeah, we appreciate it. It was a nice try.
For time, is it okay if I invite the second panel up now and then delay the?
We're for the second panel, please go ahead. We've got folks from Umpqua Community College and Mercy Medical. I've got it right.
Yes.
And we have until 11:45-ish. So don't feel rushed. We still have some time because I'm sure you also have some great.
Was anybody joining your panel virtually, or are you all here in person? Okay, great. I'm so glad you're all here.
Please turn and introduce yourselves.
us down and address nursing at College Roseburg.
And Danny Weiser, I'm clinical educator and RN resident coordinator at Mercy Medical Center Roseburg.
And I'm Holly Cook, and I'm the Chief Care Officer at Mercy Medical Center in Roseburg. And thank you for having us. Appreciate it. We're just stepping out. Appreciate our partners and colleagues, Klamath Falls. Super excited to hear the thing they have in place, and it's kind of reassuring to know that we'll be able to tag on to some of the programs that they've instituted. I'll just say creative minds are thinking very similarly. So again, thank you for having us.
So we were asked to come and speak with you is about challenges of clinical placement in rural healthcare and our partnerships with our nursing school and clinical partnerships. So wanted to start out with some of the things that are the challenges and then work into what we're doing to address those challenges. So one of the biggest challenges that we face deals with our service area that we work within. And we have a county of 110,000 people. Can't remember the square miles. Huge county. We're the only hospital other than Critical Access Hospital on the coast. The next closest hospitals are a little over an hour north and south of us. And we have I-5 that runs directly through the center of our county. So our little hospital, we have about 45,000 ER visits a year and a 26-bed ER. Well, within our hospital, we have clinical placement of nursing students, first year, second year. We have LPN students, we have EMT students, we have paramedic students. Now also have advanced practice nursing students, we PA students, and within the last 3 or 4 years, we also now have family medicine residency students coming through our facility. So for our hospital, for the size that we are, not a huge facility, but that's a lot of people coming in for education and not a whole lot of preceptors for these individuals. So the number of preceptors, the number of students coming in has been a huge barrier that we've had to try to work on overcoming. There are pieces of preceptor burnout because of how many students we have coming in at varying times throughout the year. That's another thing that we are having to work on figuring out ways to overcome. And some of the ways that we are working to work on that preceptor burnout piece is we've increased our preceptorship incentive pay up to $4.50 an hour. We're looking at preceptor recognition and having preceptor celebrations at the end of each year. And then also well-being check-ins with the preceptor throughout.
So, we have a nursing school that takes each cohort. So at any given time, that's 128 nursing students that are potentially going through a small hospital. So some of the ways that we to work with the hospital and understand, because I work with allied health at the college as well. So I'm also the one that's placing their paramedic students, their EMT students, all of those other students that we have. So we, at any given time, we have about 288 allied health students that are all placing at the local facility in some aspect. So we actually are implementing an alternative schedule. So it was really cool to hear her experience. Dorothy's, I'll have to pick her brain about it later. But so what we're doing is we're taking some of the courses for the program and we're putting them online so that the students have one core nursing class a week that's during the day. We'd love to move that to the evening or have an evening cohort, but at least it takes it from, 3 days a week that they're in person during Monday through Friday hours, and they do the online, they do one in person, and then they do a Saturday clinical. So that's actually starting in fall, and 2 cohorts, so 16 students will be in that group. So we're pretty excited about what that's going to look like for our student population. We have a pretty low socioeconomic area, and all of our students work. I mean, I don't think there's a single one that doesn't work in some aspect. And so for them to be able to work still and to manage that, because that
online courses. We've looked at our placements being really intentional and saving some of our acute care experiences for second year students that are really ready for that. And putting our first year students more utilizing long-term care, utilizing the local VA. We do a whole community rotation where the students spend an entire term out in community settings, which gives them some knowledge of community resources and also shows them like, where are your patients going when they leave the hospital, right? Like what other care is out there? What are you seeing? So that's some of the things that we've done to take that impact off the hospital.
I would just add with the flexibility of how you learn and how you are taking your classwork, we're also, again, similar to our Klamath Falls colleagues, looking at different ways that we share knowledge and expertise and those clinical adjuncts, as they were describing, of making sure that the nurses that we have, they're experts in their fields and they're experts in the different departments where they work, and wanting to add to that flexibility, the shift times and the weekend times for those clinical rotations, and groups also be able to maybe have somebody that normally works a night shift work with them on night shift and have that flexible clinical experience. Ironically, we have a meeting on Monday, I think it is, because we are really working to solidify how we grow more clinical instructors as well and harness that expertise and make it so that it's not a financial loss for them. Danny spoke to the size of the community that we serve. And one thing, I'm new to that area, but one thing I'm really proud of already, and that you can feel that palpable family and community, and people want to stay and work in their communities, serve, their friends, their families, a large area. And they also have this expertise that they want to share their knowledge as well. And so one thing we have worked toward is that acute care wage and pay. We don't want them to take a loss if they decide to really give back in a meaningful way and teach the next group of nurses coming through. And so we are committed to paying them that wage if they are also teaching at the college, and so that they aren't taking a financial loss by doing so. And again, creating more flexibility for them to, keep their skills in the acute care setting and share that knowledge. So it's something we're really excited about. Chelsea and her team are amazing partners, and they really produce amazing nurses. I'm not really even sure. I know it's a large percentage, and Danny, maybe you or Chelsea know the percentage of our employees at Mercy that did go through the UCC program. It's pretty high.
It is. I was not able to get the numbers before coming here today, but it is a large percentage of our employees are UCC nursing program graduates.
I mean, just from looking and knowing who's graduates from UCC and who's there, I mean, I would say it's probably creeping to 80% of the nursing staff that's at the hospital are UCC graduates of some length of time. And that's kind of about really speaks to the relationship, I think, because our students, for the most part, we have about a third of our cohort, sometimes a little bit less, that come from out of the area to go to school, because we do have kind of a block schedule. So they're not in school 5 days a week, and that allows travel sometimes. But for the most part, our students are local. I mean, their families are from there. They grow up knowing I'm going to go to UCC, right? We have a huge partnership with K-12, where we actually start the CNA program in the K-12. So seniors can take the CNA program through their senior year, and they graduate with
the ability to sit for their licensure. We're also, we have a PN exit program as well, which is where after the first year, our students can sit for their LPN boards. Last year, we had like 17 out of our 64 cohort that sat and got their LPN licensure, and we're working in some aspect in the community as an LPN and getting that experience before coming into their second year. So we just have this partnership. It's like, I don't have to worry about if I have an issue or we're running against something that's an issue. It's like, okay, I call Danny. I don't have to try to figure out like, who am I calling? Who am I? And so whereas there's some challenges for rural healthcare, right, with limited preceptorship, there's also this real positive arena where we know each other. Like Holly's new, but she's already like in the fold, right? Where she's already there. And our preceptors, like if we have an issue with a student, like they know who to call, they know who the face is, they know who they're looking for. So, you know, that's a huge positive piece to rural healthcare. I'd like to say that we applied for the RUNU grant and we got it. Yes. And what we're doing
You want to
with
share
that-
what that is with everyone?
Yeah. So the RUNU grant was from the OCN, and it was specific from looking at nursing retention and recruitment. So you had to come up with a project, and you had to show how that was going to impact recruitment and retention of nursing faculty, right? Because we have a really hard time with nursing faculty in a rural area, right? One of the not so bonuses of living in a rural area, getting somebody who has the expertise, that has the, you know, education requirements, all those things. And so we looked at retention. We've had some significant turnover, and part of it is pay, which was not what this grant was for. But us as a college and with our partners, we're looking at addressing that in different ways. What we found is that I polled over the last academic year, and our faculty, on top of their course that they're teaching and their clinical and their advising for the nursing program, they're spending up to 80% of their face-to-face student time outside of the classroom on non-academic needs. Because our students they're working, you know, from low socioeconomic backgrounds, they're single parents, they're coming from trauma background. There's so much stuff, and our nursing faculty are bearing the weight of all of that. You know, we have some online counseling services, but sometimes when you have a nursing program, especially at a community college, you become kind of like a little school within a school, right? And so they come to our nursing faculty because that's who they know, that's who they trust. And so we actually got approved for a position that we are pretty confident will stay full-time. And that is like the net, right? That keeps those students from falling through the cracks. We're super excited about it. They're going to do some advising. They're going to do some resource allocation. They're going to do training on, you know, trauma-informed care. Just every piece to help support not just the faculty, but the students, and take that burden off the faculty of that, lots of that non-academic time that they're spending with students. That's, you know, it's not just time, it's mentally, right? You're really worried about those students when they leave campus.
And kind of talk about that relationship and with our partner with the college and such a small community. I've been with Mercy Medical Center for almost 20 years, and vast majority, if not all of the faculty I've worked with at the hospital. So I know who they are. They know who I am. So the relationship that we have with the college helps us just as much as it helps them. Is just this last August, we started our nurse residency program. Mercy Medical Center is a member of Home and Spirit Health. We rolled out our 52-week RN residency program in all of our care areas. The next month will be the start of our largest cohort. Where Chelsea graduating
61, 5 of which were LPNs. How many did you take?
37, I think.
Yeah,
Still,
yeah,
we're talking
37 of them today.
outside.
Yeah.
I'm like, can we squeeze another one in? Can we do it all?
We've hired 37 out of their 64 cohort, 56 cohort. So that relationship that we have, we the students get to meet me, that they're going to be working with very closely throughout their residency program very early on. I meet with them early second year. I talk to them. They haven't asked me questions about the residency program, and then as I'm also the one that helps schedule their interview sessions for their practical. He sends me the list. I put their schedules together. Then they get the opportunity to manage to have when they come out of nursing school. And then with our partnership, we do career fairs, and myself and the hospital leaders come out and they get another opportunity to meet the managers. And we strive very hard to meet with them, get our positions ready and posted to where each of the students that we're going to be hiring have that job offer prior to their graduation. So they already know that they have a job as soon as they graduate.
Well, and I think what you were talking about earlier about how, you know, the leaky bucket, right? There's not a shortage of nurses. There's nurses leaving the bedside. And why? And so much of it is relationship, right? I've worked for huge hospitals where you are a number, you're an employee number, and there's no getting around that, right? You can't get around that when you're employing that many people. But there's something to be said about knowing that people know your name and people care about who you are as a person. And your manager knows your name. They talk to you in the hallway. You know, there's something about building that relationship that keeps people in their jobs, right? Because they're not just something that is disposable. Oh, I can just hire another nurse if you quit. They're a person, and you can go and have that conversation about what your concerns are and how can we make those changes. And I think that's a huge piece that we're missing, is that acknowledgement that we are people and that we do have stress, and that we need to be seen as that and not just a commodity.
I want to kind of just add on to that really briefly. Again, a conversation as we were outside waiting to come in was that of those new nurses that we've already hired, there are still 5, I believe, that don't have, that we're aware of, that don't have employment secured. And so the 3 of us actually were just kind of talking a little bit about, okay, you know, maybe go back, look at the list. Is there a department that we need to try to create another residency position for? Is there something that we can do? Because that relationship is incredibly important to us from the hospital side with our college colleagues, but with the students that are coming through, because they are our community. They live in our community. They want to stay in our community. We want to provide a place for them to utilize their skills that they have just learned and come out with. And so it's something I'm really proud of, that we do take it personally, that it is a person and not just a number and a statistic.
It's an interesting problem to have. Your hospital sister in Eastern Oregon, they shared the same thing, like they aren't having a problem with staffing. So it's an interesting problem to have. And it's this partnership that something I wanted in Southern Oregon, and I don't know if anybody has any questions or comments or discussion about it.
I do, of course.
So Board Member Hill.
So I had a question, and you sort of answered it, because I was like, okay, so you placed 37, but you had more graduates. So what are there other employment opportunities? Because Mercy cannot be the be all end all. So are there, you know, other organizations you're partnering with? And what are the employment opportunities for people in your community?
So there's a lot. I mean, there actually is a lot, amazingly, for the small area that we have. We have a VA. It's not a full service VA. It has pretty limited, but they took, I don't know how many they hired. I think 2 or 3 that were already employees there. 10 of our students were from out of the area and have accepted employment out of the area. So some of them went to the Asante system and some of them went to the Sacred Heart system up in Eugene. So 10 of those students. And then we have a partnership with a local healthcare called Aviva, and they're a federally qualified access care facility. And we have an earn to learn program with them where they interview early in the nursing students application. And once they're accepted, they apply for this earn to learn, and they actually pay for their entire nursing student. That's how I went to nursing school. I would have never been able to go to nursing school without that. And then at the end, they're guaranteed a year of employment. And obviously they're like, we want them to stay forever, but it's guaranteed, right? They commit to a year, and Aviva commits to a year. And then that's where it ends for repaying that they paid for them to go to school. And then after that, it's at will employment. So, and there's more than that, right? We have several clinics like that take our students for clinical placement and also hire our students afterwards. You're welcome.
I was really, really excited to hear that you guys are valuing people over just employees or numbers. That's really great. And one of the saddest things that I've seen in my career as a nurse is just a movement away from things like years of service recognition or company barbecues. I mean, that was really prevalent when I first started and is just over the years has kind of disappeared. So I think that kind of community and this is where we work and pride really boosts morale. So I'm excited to hear that you guys are doing that. I'm also super excited about the hospital's commitment to helping keep faculty members' skills relevant to practice today, and the financial support that you're offering these people, because that's definitely one of the things I've heard from not just clinical faculty, but nursing school faculty too, is they'll often say, like, I can make more money if I go work at the bedside, or I can make more money if I, take a job than I am at teaching. So I think that that's a very exciting thing that you guys are doing. I'm not sure how prevalent that is throughout our state. So this is the first time I've ever heard of it. So kudos, definitely.
There are definitely some. The sister hospital in Pendleton has that arrangement, but it's not super prevalent. I think I know maybe of 3.
You're talking about kind of buying the hours so that they're getting paid the same rate as clinicals faculty. So I know we're doing it at OHSU because they can do it from themselves in their school. It was the one place that I could afford to take a job and be on their faculty, was because that's how they do it. And then I think the third one, I don't want to misspeak, so nobody take me as 100%, but is it Providence in Southern Oregon
with Rogue? I think so.
Yeah, it's Rogue and Providence, and I couldn't get them here because of taking time off, but that is the other one that I know of, those 3.
Yeah, and I don't know if they've finalized it or if they're kind of where we are, like in the process of finalizing it.
Yeah. So we've been talking about it and talking about it, and I hope it continues to be a financial way to really support our faculty.
For us, it's a game changer, right? Because to get clinical faculty, often if they work at the hospital, which they almost all of them do, they have a rotating schedule. And so I need them every Tuesday, right? Or every Wednesday or every Monday. And so I have faculty that take PTO from their regular job to come and teach for us at a lower rate because they want to give back and they want to do education. So to be able to say, hey, this will be part of your regular schedule and you won't take a pay cut to do this is huge to me. I'm so excited about it. I can't even stand it because always it's hard. I always have vacancies.
And I have 2 questions. One, from your standpoint in your area, do you think that you could support another school coming in with nursing students?
Is. Yeah.
Starting to swoop.
Yeah, I think it probably isn't. Sorry, but for here right now.
Mine again is just a compliment. I do want to say that retaining is a very, very big thing, and having the relationships you guys have with your employees is huge. I know that 100% of our staff would have left or, during COVID, but having a manager that was very supportive and just continuing to do things like that is very important. We weren't a number. He was, in fact, one of the first people I called when I passed my NCLEX. I didn't even call my boyfriend. I didn't realize. He was like, you didn't even tell me. I'm like, I'm sorry. I called my manager. Doing that type of stuff. And then also speaking on the fact that having staff being will do like calls and stuff like that. There was a lot of nurses that wanted to do that, but we didn't know how. And so I think that's something to look into. So thank you guys again.
It's funny to hear the whole, barbecues and incentives, and they do all of that. They bring like food trucks and everybody. It's very cool.
Next week, I think we have our preceptor recognition. Is it next Thursday?
No, it's the end of the July.
July. Okay, we have one scheduled. We're honoring the preceptors.
Since our residency program started last year, our 1 year retention rate is up to 94%. So
I really appreciate your time, and obviously we could talk about this all day. This is really wonderful work, and it's great to hear more of it. And hopefully, it can germinate in some other places.
Thank you.
Thank
We
you.
really appreciate your time.
Yeah, thanks for having us in the community and for joining us today.
Sorry to cut it off. We're a little bit over time, and I wanted to make sure we honor the other people that are waiting online. I see for the next items. So we'll turn to policy analyst Blackhurst for four different, more than that.
Move quickly. All right, my first education item is on 227 of the packet, and this is regarding continuing approval survey of Warner Pacific University. Dr. Linda Campbell just turned her camera on. She's joining us virtually. And so, as we noted in the memo, conducting the survey, all of the evaluation standards were found to be met or partially met, and recommendations were provided to the school for the areas where they can improve on those partially met standards. And my colleague, analyst Wickenhagen, actually conducted this survey, but she had high praise for Dr. Campbell and her leadership and many of the faculty, staff, and institutional leadership at Warner Pacific. So our recommendation is to grant continuing approval to this program through December of 2031, which ideally is going to align with their next National Nursing Accreditation Survey. So I'm happy to answer any questions, or if you have any for Dr. Campbell.
Okay, please, Board Member Hill.
Yeah. So my question is, where is Warner Pacific in the process of finding a retirement replacement?
I believe Dr. Campbell can answer that.
Yes, it's our Associate Dean, Andrea Thompson. She's relatively new. She's been here for a year as faculty, but she came to us through Kaplan prep seminars. And our NCLEX RN pass rates got into the 90s from her efforts, and we're currently at 95% pass rate. So she's very engaged. She absolutely loves our mission and our students. So she begins her role officially on August 1st, and I'm here until July 31st. So we're working very hard to have a smooth transition. And we already have our Associate Dean, who is another faculty member, Dr. Rosalind Boyer-Cole. She's by specialty CRNA, and so tremendously valuable in teaching all of our scientific-minded courses. And everybody loves to collaborate, and the rest of our faculty was stable this year. So thank you very much. And thank you for a wonderful site visit. The OSBN is incredible.
Doesn't look like we have any more questions. Thank you.
All right.
I'm ready for motion.
Then I motion that Warner Pacific University's pre-licensure registered nursing education program be granted continuing approval through December 2031.
So move.
Second. Roll call. Cooksey.
Aye.
Hill, aye. Callis. Aye. Stanich. Aye. Towabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitchell. Motion carries.
All right, thank you.
Thank you so
And thank
very
you, Dr.
much.
Campbell.
Thank you. Great pleasure.
My next agenda item is on page 249 of the packet. This is regarding a continuing approval survey of Southwestern Oregon Community College's pre-licensure registered nursing program. And our guest here is Elizabeth Cooper. She is the dean. She's turned her camera on so we can see her. And this was a fantastic survey. On our visit, we found that all standards for approval were found to be met. We also noted a really impressive amount of just support for nursing students and for the nursing program from the college itself. So really wanted to raise that up. Here, my recommendation is to grant the program continuing approval for 8 years, which is the kind of the maximum we can grant approval for.
Doesn't look like we have any questions. So I'd be ready for the motion for that.
Then I motion that Southwestern Oregon Community College's pre-licensure registered nursing education program be granted continuing approval through May 2033.
So move. Second.
Roll call. Cooksey.
Aye.
Hill, aye. Callis. Aye. Stanich. Aye. Towabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitchell.
Aye.
Motion carries.
Thank you, and thank you, Liz, for being here. My third item then will be on page 276 of the packet, and this is a memo regarding a developmental application for a pre-licensure practical nursing program from Treasure Valley Community College. For this item, my guest is Mara Pointer, who we can see now on screen. As I shared in my memo, Treasure Valley Community College is actually currently approved by OSBN. They have a registered nursing program in Ontario, Oregon. Their RN program is accredited. The school previously operated a practical nursing program. What they're proposing to develop now will be potentially opening fall 2027, but yes, we're just looking to approve that developmental application so they can continue redeveloping this program. Any questions on this one?
Oh, I think we're ready for the motion. Thank you.
Well, then for this one, I motion that Treasure Valley Community College's developmental application for a pre-licensure practical nursing program be approved as presented.
So move. Second.
Roll call. Cooksey.
Aye.
Hill, aye. Callis.
Aye.
Stanich.
Aye.
Towabola.
Aye.
Dennis.
Aye.
Nesta.
Aye.
Mitchell.
Aye.
Motion carries.
All right, thank you, and thank you, Mara.
Yep.
The next item is on page 299 of the packet. And this is a memo describing a decrease in admissions at Southwestern Oregon Community College for the fall. This item does not require board action. It's just informational. And as I had noted in my memo, they're just decreasing to, from have 49 to 6 students annually down to 45. And their cited cause is simply that they're competing with themselves for clinical placements. And some of their facilities don't have like a census levels consistently to have that many students. So again, I can answer any questions you might have, but no action is needed on this one. Okay. All right. My final item is a presentation. Should I continue? I'm thinking.
Annual nursing program.
Yes.
How long? Yeah, how long is it?
10 minutes.
Yeah.
No, let's do it.
Okay. Give me a moment to share my screen. Okay, there we go. Slight delay. All right, so what I am presenting about is our annual report of Oregon nursing programs. And just to give you a little bit of background on what this is NCSBN has an annual report program where they develop a Qualtrics survey. They have standard questions for every board of nursing, every state to use. Board staff can add additional questions if we like, but we try not to add too many because it's quite a long survey as is. And then this survey is sent to all of our Oregon LPN and RN programs in early January. We ask that the programs the survey for each NCLEX code they utilize. So what I mean by that is we have some schools that have a bachelor's program, an accelerated bachelor's, a master's program. So we're trying to get data on like each of the different programs. And then it provides OSBN with data and measures of the programs broadly, but then we also look at how the programs sort of align with NCSBN's key quality indicators. So I'll get to talk about what those are. But just broadly, some of my presentation is cut off at the bottom. Okay, well, I'll narrate. So what we're looking at is the different program types in Oregon. And what you can't see is that it is 7 licensed practical nursing programs. It is 15 RN programs at the associate's level. We have 12 RN programs at the bachelor's level, 5 RN programs that are accelerated bachelors, and then 1 RN program that's actually a master's entry into nursing. We also found on this survey that in terms of location, 46% of our schools are rural, 34% are urban, and 17% consider themselves suburban. In terms of ownership, most of our schools, 66% are publicly owned. We see 24% are private, not-for-profit, and 10% of our schools are private for-profit. And then in terms of accreditation, 59% of the respondents said they currently have national nursing accreditation, which is very exciting because we just passed that in Division 21 as a new requirement. And even more excitingly is that this survey didn't really capture all of those programs that are actively candidates for accreditation or like working towards it. So 59% today have accreditation, but we know quite a few more schools are getting close. They're in that pipeline. In terms of NCLEX pass rates, so interestingly, this annual survey looked at the 5-year snapshot from 2019 to 2023, and in what we saw is something we saw nationally, that in that time period, there was generally a downward trend in pass rates during the COVID pandemic, but schools are now seeing those pass rates rebound. I thought for some helpful comparison, our second line here is the overall NCLEX pass rates across the US, and at the bottom are our Oregon pass rates. And if you notice, the pass rates for PN candidates and the pass rates for RN candidates, Oregon has higher pass rates than nationally. So it's very exciting, really a testament to our nursing programs. Moving on, faculty estimate. So on our annual survey, what I heard was that there's a little over 460 full-time faculty. There are about 324 part-time faculty, although importantly, NCSBN does say that part-time faculty is anyone who is less than 37.5 hours. And then the survey asked about the clinical adjunct faculty, and it actually divided it by those who are employed by the program or those clinical adjunct faculty who are not employed by the program. So this is where academic practice partnerships and hospitals, like we were just hearing about, where those faculty are employed technically by someone else. I do want to caution that I wouldn't take all of these numbers and add them up and say that's the total number of nursing faculty in Oregon. I suspect if you did that, you would get a big overestimate because we know that there's a lot of faculty who maybe do clinical work for a couple different schools. And so they're being counted multiple times on this survey. And then when we have programs that have multiple educational tracks, like I was describing, if one person is teaching in multiple tracks, they again be double counted. So don't total these and think that that's the total number of faculty in Oregon. It is probably a little less. In terms of our faculty education levels, you can kind of see the bottom of the key at the bottom there. We definitely see that predominantly our nursing faculty are master's prepared. We have a small number who are prepared, and then a small number are doctorally prepared, whether it's a DNP, a PhD, or there's a few nurse faculty who have another doctoral degree. In terms of curriculum and clinical, we see a big range in the amount of clinical hours. So the lowest we see is a program that has 103 total clinical hours. That is a practical nursing program. The highest we see is an RN program that has just over 1,100 clinical hours. To be really clear though, Division 21, the OARs do not establish a minimum requirement. So that is a very common educational regulatory trend because there's not good evidence for how many clinical hours you have to have for nursing school to be a nurse. So, so we do not have a set number that each school must have. We did see that clinical placements across the state are predominantly weekday, day shift. That's why some of the solutions we heard are so exciting and innovative. We found that only 6 programs reported any usage of night shift clinical. And 11 programs, I think some of these are the same, reported any usage of weekend placements. So thinking about clinical on nights, on weekends, is a great area of potential opportunity for our nursing programs. In terms of simulation, so simulation was reportedly used by 98% of our nursing programs, 40 of 41 responses. Interestingly, though, we saw a big range. And so some schools use as little as a little over 2% of simulation to replace clinical. And the highest was a school using up to a little over 41%. And again, our rules allow schools to use up to 49. So again, another huge area of growth. On average, though, the average nursing program has about 88.4 hours of simulation. And doing the math on that, we determined that that's about 10.5% of clinical experiences that are being replaced with simulation. And again, just to restate the OARs, they can go up to 49% and actually now 50% because of the changes you just approved in Division 21. Programs must have adequate resources and ensure that national simulation standards are met when they use simulation. And so that's another way that we ensure that if schools are going to use simulation, that it's really quality simulation. Moving along. So we have some data on nursing students. So for 2024, we see almost 4,700 nursing students currently enrolled. And during 2024, you can see that there's a big gap between the number of qualified applicants who are applying to nursing school versus the number that's actually being admitted. It's much lower. And then you can also see that even when students are admitted, not all students are making it to graduation. And so we see that number a little lower as well. These student demographics were reported by the nursing programs. So our nursing students in Oregon are predominantly identifying as white, not Hispanic or Latino. And I don't have that historical data on on if we're seeing like more diversity in our nursing students in Oregon. That's something I did not have the opportunity to dig into. And then moving on, so NCSBN has nursing program key quality indicators. There are 8 different indicators, and what NCSBN recommends is that the annual survey really give boards of nursing sort of a snapshot of these 8 different things to look at for nursing schools. Not to say that if they're not meeting a quality indicator close program, but it is a sign that you have a conversation with the program or talk to them about what's going on. So evidence-based indicators NCSBN has established are they want to see that programs have national accreditation. They want to see programs that have full approval from their board of nursing, that programs are not having a significant amount of organizational change and director turnover, that programs do not have less than 50% of clinical and direct care experiences. They want to see that more than 35% of faculty is employed full-time. If you have less, yeah. This is that is a good question. I don't know what their evidence and rationale was. I think my understanding is that as the faculty is more employed full-time, there's more cohesiveness of the program and the curriculum. It also shows that schools are actually investing in the program, so they have faculty who are working full-time. I don't disagree. Yeah. You know, that's a great question. And as we were working on Division 21, at one point we had put in the draft rules a requirement that our Oregon nursing programs have more than 35% of their faculty be full-time. And the input we got from our Oregon nursing programs was, well, that's not really always feasible. Sometimes we have a bunch of adjuncts because we have so many students, or sometimes we have these academic practice partnerships where the faculty isn't employed by us technically, and now we're being harmed because we're engaging in this partnership. So it is the NCSBN's quality indicator, but we actually did not move forward putting it in our administrative rules.
And I'll just add that National Council makes model rules and they make model suggestions, but they know, and they say this all the time, it's one of the reasons why they avoid getting involved in some stuff, is every state has their own needs, barriers, challenges, whether it's statute or staff.
And then the final 2 quality indicators are, it would be a concern if a school had less than a 70% graduation rate. And even newer programs, not to say that a newer program has done anything wrong, but they're new, and they may need more support from their board. And so when we look at the data for Oregon programs, I have to say you really do need to interpret these results with context. So, for example, most of our schools reported experiencing organizational change. However, when you have nursing programs that have multiple campuses and shared leadership, then when there's a turnover of an administrator high up in that institution, every campus then has to report that experienced organizational change. The not accredited, as I shared, the survey didn't really capture all of those schools that are candidates. They're working on it. I laughed actually when I noticed that some of our schools answered things incorrectly because the survey questions can be confusing and hard to understand. So for example, 3 schools said they have less than 50% direct care. They're not allowed to per our rules. So I think that just some of the questions can be a bit challenging. And so it's helpful to see what schools are saying, what they're reporting, but you must interpret these with context, and really it drives a conversation with the school. That, and if I regrouped the same data to how many flags are coming up per program, most programs are only saying one or two of these things are going on. So we're not seeing schools that are saying like all 8 things are a challenge for them. And even the 2 schools that are on the higher end that had 5 different indicators we should probably take a closer look at. They're things that, you know, we're aware of, they're new, they're working on. So the context is super important, but it's helpful for us when we work with our nursing programs. So thank you for letting me talk very quickly through that.
And I can attest to the questions being challenging because I work with the leadership team to answer when we do a survey on all the boards of nursing across the country. And I always am like, I know I probably answered these off. They're challenging. So thanks for bringing up that context.
Great. So we have 2 minutes to refreshen ourselves before our lunchtime presentation.
Mr. President, I actually just told them we needed 10 minutes and we would
Okay.
start 10 minutes late for the presentation, but to
We'll
grab
start
our food and yeah.
12:25. Wonderful. Yeah, because we have open afternoon. So if they're able, the folks from Leading Age and
Yes.
Rooting Care can stay a little later, then give them ample time.
Great.
Good.
Thank
So
you.
back at 12:25.
Great. Thank you.
Go.
All right. Well, thank you all so much for the opportunity to be in front of you all today. My name is Kristen Milligan, and I'm the CEO of Leading Age Oregon. And Leading Age Oregon is an association of affordable housing and long-term care providers. So let's see, I don't have control over my slides, I don't think. Looking at you? Okay. The next one would be great. So, oh, that's okay. That's okay. Mine's the easy part of just kind of introductions of just sharing who we are. So again, we represent kind of a large and broad spectrum of individuals that either house or provide services and care for older adults in Oregon. So throughout Oregon, we have members that are assisted living facilities. We represent all 7 of Oregon's life plan communities, also known as continuing care retirement communities. We have some hospice members. We have independent or kind of just your standalone independent living facilities. We represent HUD subsidized housing providers. Again, pretty much if you provide services or housing for adults 65 and older, that is our membership and who we serve. And then we can go to the next one. And this is who we are and how we try to provide supports and services for our members. So we do your typical association work of advocacy. We work in Salem during legislation season. And then we also, of course, work with the Oregon Department of Health and Human Services and pretty much any department that cross paths with any of our members and how they're regulated or provide supports. We do education and training. So within Leading Age Oregon, we offer an assisted living facility and residential care facility administrator training. We have preceptor training for nursing facilities. We have a leadership academy for pretty much any position of folks that are looking to find those pathways within our membership. And we also have kind of one-off workshops and symposiums that we provide as well. And then we offer peer connections and organize conferences and get our folks together to share kind of best practices amongst our membership. So today in front of you, you have the real guest speakers from one of our members here in Medford of Rogue Valley Manor. And they're going to share some of the excellent work that they do in this community. They are really a pillar of Southern Oregon. And I mean, they are an absolute they're fantastic in this community and provide amazing supports and services. And they are really an organization that I think a lot of older adult providers could be looking to as to how they can and should be providing and serving seniors in our community. So Melissa and Bonnie.
Thank you, Kristen. I'll introduce myself. I'm Melissa Preston. I am Associate Executive Director for Rogue Valley Manor, which is a life plan community located in Medford, Oregon. We've been there since 1961, through local churches that came together with the mission to serve seniors in Southern Oregon, and we've been doing it ever since.
And okay, how's that? I'm Bonnie Marshall. I am a registered nurse and I am the Director of Staff Development at Rogue Valley Manor. And we'll be talking about our program and some of the goals that we've set and accomplished.
Ready, next slide, please. So just a little bit about Rogue Valley Manor and what we do. Our mission is to lead meaningful lives together. And one of the most powerful ways that we do that is by investing in career development for our team members. When we support the people that care for others and improve the retention and recruitment of those folks, we build a thriving workplace where we can grow people and find our purpose going hand in hand with the residents that we serve. We believe that strong careers in healthcare begin with a strong foundation. And so our goal is to cultivate an environment where employees are empowered and supported and given real opportunities to advance. This in turn directly improves the lives of the residents that we are here to serve. Our vision is simple but powerful: to create a community where both staff and residents grow together. And so, like I said, since 1961, as a life plan community, Rogue Valley Manor has been offering a full continuum of care, ranging from independent living and home care to residential care, memory care, and skilled nursing. Everything we do is grounded in our values: integrity, compassion, innovation, and stewardship. We're also very proud to be a not-for-profit organization, which means that the resources beyond our expenses are reinvested back into our community, into new programs, enhanced services, and improved living spaces. And so that's why we were able to launch our certification programs that we have, because our residents have supported those programs with the profits that we've made. The Rogue Valley Manor Foundation plays a key role in this, whether it's by providing transportation, offering scholarships for staff, or supporting our residents who have outlived their financial resources. And so moving into our presentation for today, I just want to share some of the strategies that we've implemented that have helped us to recruit and retain staff and have really positively impacted our culture in our community. Next slide, Danny. Just over 3 years ago, as we were emerging from the COVID-19 pandemic, we faced a significant challenge that is probably very familiar to everyone in this room, a staffing crisis. Like many organizations struggled to fill the crucial roles in our skilled nurse facility care and residential care facility with caregivers, med techs, CNAs, CMAs, and nurses. And we knew that we had to be part of the solution to this problem. So we started with curiosity, and we went to the people that know the best, our staff. And we asked them 3 simple questions. What are you looking for in a career? What are the barriers keeping you from getting there? And finally, why are the people leaving this area? Why are they leaving this work? Because the heart that it takes to do this work is there in the population that's working with us, but we weren't making it easy for them to stay in the field. The answers were clear, and the need for a solution was urgent. And so we turned that insight into action. And we discovered that to support recruitment and retention, we had to move quickly and think boldly. We needed to create meaningful growth and educational opportunities that were accessible to everyone. We needed to improve how we welcome and support the people new to our industry. And we had to reimagine our training culture from the ground up. And these findings really helped shape the program and approach that we implemented. So why do people leave? When we asked the questions, the answers were clear: orientation and training. Too often it felt unwelcoming, inconsistent, or just simply lacking attention. And that's why we built a strong preceptor program to guide and support new staff from day one. Another area that we were finding a gap in was culture and community. Many staff felt disconnected from their coworkers and the purpose of the work that they were doing. There was a lack of growth opportunities that were laid out and easily accessible to people. And that's where our NA and our MA certification program came into play, offering structured pathways for advancement in multiple areas. Compensation was another factor, and we recognized that pay matters. And so our focus on growth included opportunities that led to wage increases throughout the training and promotion process, because it wasn't just about retention, it was about creating a workplace where people wanted to stay and grow. In this photo, you'll see Mariah and Tristan, both caregivers in our Memory Support Center. They are not only dedicated team members, but also graduates of our nursing assistant training program. After completing the course, became certified nursing assistants, preceptors, helping to mentor the next generation of caregivers coming through our program. You'll also see Rena. She initially applied for a previous cohort due to the high volume of applicants that we received. But rather than giving up, she followed our and applied to be a caregiver in our residential care facility. She was hired, began gaining experience, and when the next cohort opened, she applied again and was accepted into the program. And then there's Bradley. He joined us as a nursing assistant student and now works as a CNA in our health center. But his journey doesn't stop there. He was recently accepted into nursing school where he will begin in the fall, supported by the Rogue Valley Manor Scholarship Program.
All right, so this picture is a picture of Jessica. She's administering a meter dose inhaler to Jessica. Jessica is a fabulous example of one of our staff members who have taken every opportunity that's been given her. She started in housekeeping and then became a CNA before we started our program, so she wasn't one of my CNA students. She showed leadership skills and potential, and so she was then trained as a preceptor. She was one of the first students to take our CMA class and also trained to be a restorative aide. She's now taking prerequisites and planning to apply for nursing school next spring. So we are cultivating career growth opportunities through a number of different options. So if you want to click. Okay, dining assistant. For those who are interested in caregiving, but they're not sure if that's really the path for them, this is a great option for them. It's a great option for high school students who are working part-time and again, want to get into healthcare, but are just want to get a taste of what we do. Staff members can be as young as 16 to be eligible to take the DHS approved 16-hour course. Should I say click? Should I just give you a wink? Then we have caregivers or resident care assistants. Certification, of course, is not necessary to work in our residential care facility or memory support or home care. But this is a great place to start developing those skills before committing to the certification. BLS and first aid certification. This is a requirement for most of our areas, but anyone on staff, whether it be security or facilities or a health services staff, can take this class for free of charge. Then we have our CNA. We open up the opportunity for staff who are in good standing to be paid an hourly wage while taking the NA class. So they cut back, if they're a full-time employee, they'll cut back and work on the floor a couple days, and then they'll be in class the remaining of their 40 hours. So they're paid to be in class. And then that qualifies them, of course, to take the exam to become certified. We also open it up in order to recruit applicants and new staff. So they're brought on as employees as well and paid to take the class. We ask that they're willing to commit to a year of employment with us. Some of them stay, some of them move on. In the last photo you saw, we have a mix of current and new staff in each cohort. So it's about 50% of current staff and new staff. We were able to create a program that it integrates the values and culture of our company into the curriculum. We involve residents in our classes. On our second day, after we talk about communication, we schedule for them to do a resident interview with one of our resident volunteers, and that is one of the highlights of the program. They go in and they're a little nervous and they've got a little guideline to help get them started, but then I can't get them to stop. I'm like, we have to go back. So it's definitely a highlight of the program. We also invite resident volunteers to participate in a blood pressure clinic. So once we learn about blood pressure and they learn how to take a blood pressure, then we invite residents so they get a lot of extra practice. And then that's also another opportunity to practice their communication skills and just that one-on-one connection. Our clinical experiences are held on our own campus in our licensed areas so that by the end of the class, the students can choose which area they want to work in. So if they really loved memory care and were passionate about memory care, then that could be the area that they go into or go into our skilled nursing facility or residential care. Then we have our CNAs. So staff who've been with the RVM for a minimum of a year and who are CNAs with a minimum of 6 months experience can apply and be paid again an hourly wage to take the class. The clinical experiences are held on campus, and those who take this class are ready to transition into this new role. So they do their clinicals in our skilled nursing facility, and then they just move right into training once they become certified. It's an excellent step towards nursing school as the CMAs are able to become familiar with pharmacology and start building their knowledge of a variety of medications. So they're really immersed in that environment. I currently have 5 CMAs and MA students who are actively working towards acceptance in a nursing school. Then we have restorative aid. CNAs who work in our skilled nursing and who are in good standing are able to take our restorative aid course. We also have Halcyon training. Halcyon's training is for staff members who work in our memory support center, and it is a as empathy and sensitivity-based training. It's hands-on intensive course that is a state DHS-approved pre-service dementia training program. Then we have our preceptors, and our preceptors were key to this whole thing. Think about when you first started your first job, right? The first day, were you welcomed? Did someone take you under their wing and introduce you? Or did you show up and people are like, oh, we have someone to train. Who's training? I didn't know I was training, right? Has anyone had that experience? That happens sometimes, and we feel like that was really something that we needed to address. So the preceptor training was already created. We just had to implement it. So the preceptors are trained in leadership skills. They're trained to help bring those new staff members. So not only do they go through the typical checklists of, do you know how to do this, 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 and this, right? But they meet them on their first day at the door. They welcome them, they introduce them, they help integrate them into the team. Let's see. We know that it takes a good solid year to really get solid in a new position. So the preceptor, part of the idea of this program is that they remain connected with that new employee throughout their first year. So they'll meet periodically, and that gives the new employee someone to go to, like, hey, I haven't experienced this before. What do I do here? I'm struggling. Maybe it's 6 months into their employment. They've still got someone that they can go to. We provide additional leadership training opportunities for them throughout the year so that they're continually learning and growing as preceptors. They're involved in other projects as well. So not only are they training new staff, but they get involved and help with our semi-annual skills fair. They lead booths. I have one preceptor. She's a CNA in our skilled nursing. She is passionate about bed making. Like, you need to make the beds, you need to make them right. And this is why. So she comes to my CNA class when we talk about bed making and she demonstrates. And then she even called me out in clinical. And she's like, you're killing me, Smalls. So it's great. It's a great opportunity for them, and it helps give them that additional step and purpose. There's such a key piece to the success of our program that we give them a little key, a little key lapel pin when they complete the training. Then we cultivate more growth and opportunities through financial assistance from our foundation. It includes scholarships, tuition reimbursement, and workplace development. This provides additional support for staff for their continued growth in their careers. There's no one single way to grow at Rogue Valley Manor. People can enter and create their own path depending on their interest, their current skill set, and availability of the classes. Next slide. So we make learning fun. We use a variety of tools, including games, to keep learning fun. We play infection control Jeopardy. And as shown in this picture, vocabulary Jenga. And this came from one of our NA meetings. Someone did this, so I used their idea. Each Jenga block has a vocabulary word that the student defines. When they pull it out, they have to define it and talk about it. And one more click. So we don't just grow careers, we grow people. We build connection, pride, and a sense of purpose through every training and career milestone. As I talked about before, we actively involve residents in our education programs through life story interviews, blood pressure clinics, and this provides students with meaningful real-world patient interactions. Our curriculum is enriched by the expertise of campus professionals across a range of specialties. For example, we have our infection preventionists come and do the unit on infection control. We have our social worker come and teach a unit on self-care and burnout prevention. The dementia unit is taught in part by our Memory Support Center administrator, and our wellness director leads instruction on body mechanics. This collaborative approach allows students to engage with various campus leaders, learn from experienced professionals, and gain insight into different specialties and careers within geriatric and community-based care. We celebrate each student's success. Our foundation sponsors a graduation for each cohort. It's a luncheon. The students get to choose who they want to cater, what kind of food they want. Graduation includes a short ceremony, a presentation of their completion certificates, another little pin, a stethoscope pin, and their own blood pressure cuff. Sometimes the students want to speak at graduation, like it's a big deal. They invite family and friends. We usually have like 30 people. We invite the executive team and different leaders from around campus to come and celebrate. We really try to make the day special because for many of these students, it's a really big deal. And for some of them, they haven't had a graduation ceremony before. Next slide. This one's us.
So we'll revisit the original challenges that we identified, those root causes that were really contributing to our staff turnover and burnout. What we built isn't about a recruitment pipeline, it is a strategy for retention. We've addressed the lack of engaging orientation through our preceptor program. New staff are welcomed and supported by experienced team members who walk alongside them through their journey. We've elevated the training experience by embedding hands-on learning, mentorship, and a culture of continuous improvement, all driven by those same preceptors. They know the best because they're the ones that are right out there on the floor alongside our new CNAs, seeing where there might be gaps. To foster connection and belonging, we invite the directors and administrators to meet with our new hires during the training, like Bonnie described, and to establish across all departments early on that leadership is invested in the growth of our teammates. We've tackled the barrier of limited growth opportunities through our program by providing paid training tactics. By offering staff paid training, we removed a significant barrier for people being able to grow their careers. And finally, because we know compensation matters, each step in our growth process does include a wage enhancement opportunity as well.
We have held 9 NA training cohorts. On average, we have over 100 external applicants for each of our NA classes. Our target class size is 8 due to our space and the size of our facility. So with approximately 50% of the class being internal employees looking to grow, that means we have about 100 applicants for 4 slots. So there's definitely interest out there. Our class age ranges from 18 to 66 years old. So I love that. I love the blend of ages in class. When I went to nursing school, that's how my class was. I was the youngest one, and we had clear up. I don't know how old the oldest one was. She may have been close to 60. But this wide range of ages means that they all have something to bring and learn from each other. We have had 66 NA students across the 9 cohorts, with 63 of those graduating. We had 2 that had to back out before completing the course, and 1 had to be dismissed from the course. 50 of those 63 graduates, 52 have passed state exams and are now certified. There are several who chose not to take the exam. Initially, we were not a testing site, and it was very difficult for our students to coordinate testing. Some of them had to travel as far as Portland. So we became a testing site, and once we did that, 100% of our students were able to take the exam. We have 1 student that did not pass before his year was up, so he did not become certified. I have another student who's scheduled to retake her exam next month. Let's see. We've had 31 internal employees and 35 external applicants who were accepted. The goal was for graduates to commit and remain employed at RVM for at least 1 year after graduation. Our statistics show that we have better retention rates with our internal candidates. So out of our 31 internal candidates, 21 of those have completed their 1 year. Out of our 35 external candidates, 16 of those have remained. One of which was in my first cohort, and she's still with us, so 3 years later. We are just finishing up our second MA cohort. At this time, our MA class is open to employees only, and they have to have been employed with our VM for at least a year, and of course, be CNAs. We've had 100% of our students complete the training, and 100% have passed. Now, that's a class, one class of 4, the second class of 5. Only one of the 5 has been able to take her exam yet. So we're talking little numbers, but it's significant for us. 100% of the CMAs who graduated from the cohort are still actively employed with RVM. I believe all of my CMAs and my MA students are preceptors. Let's see, next slide.
And as you can see from this slide, the outcomes of our efforts we feel are very meaningful and have had an impact on our community, not just in numbers, but in the lives and the careers of the people that we work alongside of. As Bonnie shared, we've completed 9 cohorts. We have 2 of our CNAs who have recently been accepted into nursing school. We have 42 trained preceptors, which means our new team members have an army of people there to support them, which is exactly what we were hoping to build. And we've had 35 internal promotions, which means that people are able to grow their career and move forward in their career while staying with the same employer. And this is honestly, this is what happens when workforce development is not just a checkbox, it's a core strategy to what we're doing every day. So with that, I'd like to open it up to any questions that y'all might have for us, and just thank you for the opportunity to be here and share with you about what we're doing.
Just say, oh, do you have something? Go for it.
Question and then a comment and a compliment with that. You speak of my world because I come from CBC, so I think it's wonderful. I even took some notes on my own here to take back. The question that I have though is, out of the 100 spots or 100 people, the 4 spots that you have, do you kind of work within the community to find them something in that regards? Because you don't just turn them away, do you?
So if they're not accepted into the class, anyone that we interview for the class, if they're not accepted into the class, we try to find a space within the community for them to start with, because the class space is limited and there's been such a high volume of really great applicants. If there's an opportunity for them to be a caregiver or a housekeeper, anything to get them in the door and allow them to continue to grow, we try to do so. Yeah.
And then the compliment is, I think it's so important. The preceptor meets them at the door. I can't tell you how many countless people we lose because of not doing that simple thing of just supporting them at the front door. So your program is wonderful. I think that's why it's successful, and I have to compliment you on that. So
thank you.
I cut my teeth as a MA medical assistant, and I think nursing education inherently has to be experiential. So I love that you all are integrating that piece, and with the steps, this is really this is a great model, I think, for other places and for all of us to start at some point and continue to expand. So thank you so much for your time and being flexible with it today.
Thank you.
Thank you very much.
And like our board president, I also started as a CNA and then became an RN and then became an APRN. And, you know, the last 10 years was going into long-term care as a nurse practitioner and being reminded every day about how hard our CNAs work. And I just wanted the board to really get a kind of cross-sectional view of what I learned on the listening tour when I was in Southern Oregon. And I was you know, deeply impressed by how you support them by paying for them to take the program, and hope that more and more of what you all heard today from a cross-section of from CNA trainings, education, workforce retention, academia, clinical partnerships, it's all the stuff we're always talking about. So I hope today provided a little bit of that cross-section And if I'm wondering if anybody else has anything to say or comment or question on the board before I jump into one more thing. Okay, well then, while you all are still here, we are going to celebrate Miss Barbara Zhu and our kind of CNA guru legend, who today we didn't have these huge presentations of body of work to do because we've been doing them so much. And today it was this kind of celebration of, wow, July 1st, so many things are about to become real, whether it's CNA or the Division 21, but the CNA work is huge. And I'm glad there's some people from Southern Oregon to also celebrate what I heard called a legend last night. So we just want to celebrate you. We have flower, pin, card, and an opportunity for you to speak to your upcoming retirement. And then for anybody from the board who shared words last night over dinner might want to also hear. But Barbara, we just all from the bottom of our heart are so thankful for the work that you've done and leave behind for everything, but especially the work on in the CNA space, because it is such an important part of everything we do and the stepping stone into a career pathway, whether you remain a CNA and grow and become a preceptor, or you move into another entry point. So thank you on behalf of all of us, but I will allow others to say if they want to, but please.
Well, I'm just so honored and humbled. So I'm just so shocked. So I don't know what to say other than it's been, thank you. I have to say, it's been an honor and privilege to end my career of 41 years in nursing at OSBN. During the last 4 years working in this role, I had also the privilege and honor of working with amazing, leaders across the state, not just the Portland Metro, but across the state. And Bonnie Marshall has been, Kristen, and Debbie. So all these amazing people, along with practice partners, program directors across the state, have just really made the collaboration and partnership and really responding to the needs that we have in Oregon, which changed, I think, significantly over the course of COVID more so. And so I'm just so honored to be part of amazing OSBN board staff, leadership, and this board to really carry out the mission. And really very humbling and honoring to have been part of that and hopefully made a little bit of difference. So thank you for all your support, guidance, and making the work meaningful and rewarding. So thank you very much.
And I don't know if anybody from the board or staff want to share any words too. We don't have anybody that has signed up for public comment. So a little bit of time before we close out with one last piece on the agenda that I had.
Just a little short snippet.
Please,
Just want to,
please.
it's been amazing to work with you for the duration that you've been in that position. You are going to be greatly missed. And I just want to extend my thanks to you, coming and joining the team, jumping right in and making so many amazing accomplishments with the work that you're doing. And also, she is the best co-pilot for commuting, so.
We have a long ride back, so
Yes.
one more.
I said it last night and I'll say it again. I think there's just one word and it's legend. It takes a lot to be called that. I know that. And you definitely defy that.
Thank you.
Well, I just want to say thank you because you've been amazing since I've been that long, but I've learned so much from you. I always actually like sitting in the corner, hoping that osmosis, the knobs will come to me. But thank you for your leadership.
Well, I will miss all of you for sure.
I'm gonna miss sitting in the corner next to you. When Joni's not sitting there and I'm sitting there and you're sitting there. You're amazing. You're amazing than words can actually say. It's everybody's amazing. And first time I met Barbara, she's very welcoming. So has everyone been on the board, and it's so nice. And I know I'm gonna miss her. She has her little comments, and I'm like, huh? Can you repeat that again? She's like, well, this is what I was thinking. I'm like, you know what? I was thinking the same. She's affirming. She's very attentive. She listens to your version. She tries to gauge where you're coming from, and she's a legend. Barbara, legend you.
Okay. I know there'll be more celebrations along the way because it's not your last day. It's just your last board, but will be your last day soon. So thank you all. Thank you for having us in your community and joining our community in the celebration of, just CNA in all the different ways. So thank you. And then there's no sign up for public forum testimony online. So I do just want to offer, I don't want to embarrass them because they're talking now, but there have been two people with us in our public the whole time in between others coming in and out. This is an opportunity for anybody in the public who wants to sign up and speak to anything up to 5 minutes. So I just wanted to throw it out to you, to you both, because to have someone say they've been wanting to come to a board meeting for decades but couldn't never get to Portland Metro is a huge thing. So yeah, Narayan for 53 years and has not been able to attend a meeting. So you're welcome to come join and speak to anything if you want. No, they both are declining, but I wanted to make sure. And thank you for your 53 years of nursing service. So then that brings us to jumping to my last piece, and then we can end early. I think obviously we'll have to stay till 1:30 in case somebody joins to speak to it. But while we wait, I can jump into that last piece that you need to vote on. So, at 1:30, we will be done.
Rachel,
Yes.
are we all going to meet somewhere for?
Have a picture.
Yes.
Yes, we are. At the very end, and it's been asked that we all take a picture. And so I tried to today as much as possible remember to take pictures of the panels, but I forgot one. I'll ask for forgiveness. Okay, members of the board, can I please draw your attention to page 305? Take a deep breath getting back into this work. Okay, so in November of 2024, a policy titled Behavioral Health and Substance Use Disorder Monitoring was presented to the board for review and approval. During my last 6 months working on the Health Professional Service Program, I realized that there were a crucial missing component in the Oregon State Board of Nursing internal policy. And as we worked on Division 70, which we discussed this morning, I identified that the internal policy that I brought to you all didn't include monitoring for the mental health diagnosis that does not involve substance use diagnosis. So I respectfully request that the board initiate a motion to update the behavioral health and substance use disorder monitoring policy to include a monitoring timeline for mental health diagnosis for 2 years and a timeline for substance use disorders with and without co-occurring mental health diagnosis for 3 years. So this was the one policy and procedure I brought forth as a way to make sure that the work that the board was sharing, I was capturing. It's been kind of the work the compliance specialist, investigations manager Ferris and I have been focusing on. So we are very prepared for when we get back into the health professional service program. So again, I was trying to align the work in Division 70 I brought earlier and make sure that one policy that you all have see and that we build all the other internal smaller policy and procedures from, that it's correct. And then I will just give you a preview of what I'm working on. And it's to have every policy and procedure that has to do with compliance, health professional service program, probation monitoring transparent on our website. And then I'm also updating the the course that worksite monitors take to then take the test. So that has the updated language and the updated information. So yeah, I'm here to answer any questions that come up, even though this has been before you and voted on, except for that one piece. Always open to hear discussion and questions.
I just thought it was great. Thank you.
Thank you.
I really appreciate Director Prusak that we are including mental health. I think this is so valuable as a tool.
Yeah, and it was how it was. 2 years for that and 3 years for substance use disorder. I just missed it when I created the first policy. And we've been missing it by not being in it, but yeah, yes. All right, looks like I've heard from anyone who wants to make a comment.
I think we're ready for a motion.
Okay, so I make a motion that the board approves the addition of a monitoring timeline of 2 years for mental health diagnosis and 3 years for substance use disorders with or without mental health diagnosis.
So move.
Second.
Roll call. Marcus Cooksey.
Aye.
Margaret Hill, aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Lee Nesta.
Aye.
And Rachel Mitzel.
Aye.
The motion passes, and I want to give a huge shout out to Rachel Dennis for bearing with us today remotely. Thank you so much.
It wasn't as bad as I was expecting, so we're all good.
Well, I miss your insights, and perhaps we should have turned to you because I'm sure you always have really thoughtful insights as well as kind of different angles. So I wish we would have turned more because you probably would have turned over some new things.
I think board member Dennis would have let us know if she had something to say, probably. So we should stay till 1:30 to make sure no one arrives virtually, and then we would be done. So why don't we take a picture? And where should we set up?
Brandy, thank you for lunch both days too, and for accommodating us in the hotel and everything. I know you had a big job.
The meeting is adjourned at 1:30 p.m.